All right, guys, we might get underway. Sorry about the confusion for the event. I know I've told a lot of people today that it's at 6:30. That's when I was meant to turn up. So good thing I turned up early. So for those of you who don't know me, my name's Sarthak. I'm in 4th year this year, and I'm doing the Cardiology Revision Lecture. Hi, Krishna. So I understand, and I've said this to a fair few people, that 3 weeks into semester, I don't really expect you to know a whole lot. So you'll be relieved to know that. And this is probably going to be a lot of teaching as opposed to any form of revision. But while making the slides, I tried to keep in mind that you'll probably look back on this 6 months down when you realize you haven't done anything all year and you should probably start cramming for exams. So hopefully it's useful then. So we might get started. In terms of what I'm hoping, before we get into it, is anyone aware of any groups of people currently on their way? No? Good. So what I'm hoping to cover today, the UMAT doesn't test creativity, so I'm not a creative person. So this is how I chose to break down cardiology, which I'm pretty sure is how every textbook known to man does it. So I'm going to be talking about cardiovascular disease and cardiac failure, which is where I'm probably going to spend most of my time, probably the better part of an hour. And then sort of towards the end, we'll do the less commonly assessed stuff, but stuff that's important to know nonetheless. And I've chucked in EMQs throughout. I'll pick on people as we go along. I probably won't pick on people in my Vespa, so you guys can rest in peace, because I know you guys have seen most of these questions already. So with that in mind, let's get cracking. So I'm told you guys do well with memes. I don't, but here's some memes. They're not very funny. So let's start with cardiovascular disease. So when I say cardiovascular disease, I mean any sort of condition that's related to atherosclerosis as its primary etiology. Of course, most of these conditions have other underlying etiologies as well. But by and large, atherosclerosis and the risk factors associated with atherosclerosis, such as diabetes, hypertension, smoking, hyperlipidemia, these are the things we associate with them. So I'm not going to read everything out. As I said, this is something that I had more in mind that you would look back on closer to your exam. So it's very exhaustive. I'm just going to talk about the main stuff. Everything bolded in red and blue is stuff that I reckon you should definitely know for your exams. Everything else, great if you know it. You can probably still pass if you don't. So aortic aneurysm. So as I'm sure you have heard in pre-clin, it's a dilatation of the aortic lumen. The technical definition is by 50% or 1.5% times its normal size. And we're going to be talking mainly about aortic aneurysm and aortic dissection, but aneurysms can involve other vessels as well. You can get them in your cerebral vasculature. You can get them in the large vessels of the lower limbs. So in terms of classifying aortic aneurysms, you've got 2 ways of classifying it. You can classify it by its anatomical location, which is generally thoracic versus abdominal. So remembering your aorta is thoracic all the way up to the loop, and then it's abdominal as it goes down. And then you can classify it as true versus false aneurysms. So when I say true versus false aneurysms, okay, that works. So if you have a look at these 2 images, in a true aneurysm, you'll notice all 3 layers of the arterial wall, the intima, the media, and the adventitia, they're all part of the aneurysmal sac. In contrast to a pseudoaneurysm, you've only got 1 or 2 of those layers forming the sac. So that's the difference. In terms of why we worry about it, it's purely an anatomical sort of difference. But in terms of the true aneurysms, we can also subdivide them further based on their pathological cause. So you can get saccular or berry aneurysms, which is this top one over here. That's seen in atheromatous disease. And then you've got the dilated type, which is more of a concentric symmetrical dilatation. That's seen in Marfan syndrome. That's probably stuff that you don't necessarily need to remember. So in terms of the types of the aortic aneurysm, we've got abdominal, which are by far the most common, followed by thoracic, followed by the ascending aorta. So the ascending aorta is technically a part of the thoracic, but when I say thoracic, I meant more the loop of the aorta or the arch of the aorta. In terms of its epidemiology, as with almost all of these diseases, you'll notice that men tend to have a greater level of incidence. And it's a disease of the elderly, again, in keeping with most of the vascular diseases we'll be talking about. So it'll tend to present in 65 to 75-year-olds asymptomatically. You'll pick it up on exam, on a physical exam, and in 75 to 85-year-olds, it's when it ruptures, which is what we'll talk about in a second. So you've got the usual risk factors, which I'm sure has been grilled into you over the past 2 and a bit years, you know, old age, being male, having hypertension, a family history, a past medical history of vascular disease, high cholesterol, smoking. The interesting thing here, though, is that being a non-diabetic is a risk factor. So diabetics are relatively protected, which is one of those weird things that I thought was interesting. So in terms of etiology, by and large, it's atherosclerotic disease, but then you can also get infection of the aorta, and you can get connective tissue diseases, which I'm not going to touch on today. Marfan's is an example of it. Nikki Carter will talk to you about that in her rheumatology lecture. So that's something to watch out for further down the track. Clinical presentation-wise, these things tend to either present as incidental-omas, so you'll do an ultrasound or a CT and you see an aneurysm, or they're going to present with rupture. So that's how they most commonly present. In terms of a AAA, the symptoms are, this is your buzzword presentation. You've got severe epigastric pain radiating to the back, and that can be associated with other things. So because there's turbulent flow over the aneurysm sac, you might form a clot. The clot might flick off and cause emboli to the lower limbs, or you can get occlusion of the aorta. You can get, you know, DVTs. But the buzzword presentation of a ruptured AAA is going to be epigastric pain radiating to the back. If it's not ruptured, you can still get presentation, which is uncommon, but that'll be due to compression of other abdominal structures. So there's a buzzword triad of a AAA. You get the epigastric pain. They're hypotensive because, as you can imagine, they're bleeding out into their abdominal cavity. And they've also got a pulsatile abdominal mass, not muscle. So when you examine them, they'll have a pulsatile mass. In terms of a thoracic aortic aneurysm, again, it's asymptomatic unless it's compressing on structures such as the recurrent laryngeal nerve. So in that case, it'll cause something like hoarseness, but otherwise it's going to be asymptomatic until it ruptures, which is when it's going to cause acute chest pain. And the classic sign for ruptured thoracic aneurysm will be differential blood pressures on arms, which is also seen with aortic dissection, which we'll talk about in a bit. Investigations wise, if this is a condition which comes up on your OSCEs, it's probably going to be a rupture. Don't wait for investigations. So for an aortic aneurysm, which you'll abdominal aortic aneurysm, which you'll remember I said was the most common type, the stats are roughly 50% will make it to hospital, 50% die when they get it. And of the 50% that made it to hospital and to theatre, 50% of those will die. So just starting off with a rupture, you're looking at 25% raw survival rate. So unless it's detected incidentally, you don't go for investigations. If you do pick it up incidentally on a clinical exam or on a scan of some sort, the way to keep tracking it is to do ultrasounds. So you do serial ultrasounds, and the ultrasounds are used to guide what your management of the aneurysm is going to be. So ruptured aneurysms, you take them straight to theatre. They either have cardiothoracic surgery if it's a thoracic aneurysm, or they have laparotomy if it's abdominal aneurysm. And they're going to need transfusions, obviously, to bump up the hemoglobin. In terms of the asymptomatic aneurysms, we sort of tend to classify them as being small, which is less than 5.5 centimeters. And for these, you just keep on doing ultrasounds every 6 to 12 months. Keep an eye on it because the natural history of an aneurysm is it will get bigger and it will eventually rupture. So it's very important to keep an eye on them. If they are symptomatic because they're compressing on something, or they're large, so they're greater than 5.5 centimeters, or they're expanding at more than 1 centimeter per year. Again, these are all numbers you probably don't need to remember. If you just remember small versus large, that'll be enough. These people have a greater risk of it rupturing than the risk of surgery. So these are the people you take for elective repair. And that's aortic aneurysm in a nutshell. Everyone happy with that? Awesome. So let's talk about aortic dissection now. Now it's easy to get the two confused. So remember we said an aortic aneurysm, the way I like to think of it, an aortic aneurysm is you've got plaque in the aorta. Think of the plaque as a dumbbell or some sort of weight sitting on a floor. If you leave it there for long enough, it'll cause the walls to sag and you get the bulge, which is your aneurysmal sac. Dissection is slightly different. Dissection is where you get a tear in the innermost layer of the aorta, the intima, And basically what happens is that the force of blood in the aorta sort of causes that tear to get bigger and creates a false lumen. So if this is your major lumen of the aorta, a tear in there allows blood to form a false lumen. So the reason we worry about this is that as this extends along the arch of the aorta and down into the abdomen, the thorax and abdomen, it starts occluding branches coming off the aorta. So if you occlude the carotids, you get a stroke-like picture. They'll present with hemiplegia. If you occlude the subclavians, they get acute limb ischemia of the arms. The arms lose their blood supply. If you occlude the anterior spinal artery, which is one of those small arteries no one really ever remembers, you'll have to remember it for neuro this year though, it causes paraplegia. If it reaches the renal artery, so it's gone all the way down, or if it started lower down in the abdomen, you start getting acute kidney injury because renal blood supply is compromised. So this is the reason we tend to worry about it. Again, more common in men, and it presents earlier in people with conditions like Marfan's, so connective tissue diseases. Otherwise, it's a disease of the elderly, as with all the diseases. And the risk factors are exactly the same. So that's something easy to remember. In terms of what causes it, it's almost entirely always caused by hypertension, but then you also have these weird and wonderful things. So connective tissue diseases, and increasingly iatrogenic causes. So cardiologists love to stick catheters into your femoral vessels, and they love to go up into the aorta, but they can also cause a tear. So in effect, you're creating a dissection by causing the tear. So it's important to ask that as a potential risk factor. Now, I know this sounds like a bit of academic nerdiness that you don't need to know. I'm going to emphasize this though, classifying aortic dissection. When I was in your position last year, I didn't think it was relevant until I got asked by a tutor what it was, because the management of different types of dissections is very different. So classifying it is actually really simple. If you think of the anatomy of the aorta, arises from the left ventricle, goes up into the arch, you remember all those big branches coming off it. One of those branches was the left subclavian. So the way we classify an aortic aneurysm is by calling it a Stanford A or a type A or a Stanford B. So Stanford A, these are the more common ones. These involve the ascending aorta and are proximal to the left subclavian. The reason we need to know if they're Stanford A is these people need to go to theatre for surgical management. If it's Stanford B, it's distal, so it might involve the descending aorta. So it's distal to the left subclavian, and these people are managed medically with antihypertensives. So that's the reason for distinguishing the two. So in terms of presentation, again, your buzzword presentation, acute severe tearing central chest pain radiating to the back, and they might give a history of migratory pain. They might say it started higher up my back, now it's moving down. So that's basically the tear progressing further down. In terms of the signs you need to know, so you've got asymmetrical blood pressure and pulses on either side, and you might also have absent pulses if you've occluded a vessel. So if you occlude the subclavian, you might not find a radial pulse on that side or a brachial pulse on that side. And the last thing it can do is it can rupture into adjacent thoracic structures. So it can rupture into the pleura and cause a pleural effusion, or it can rupture into the pericardium and cause cardiac tamponade, which is a condition we'll talk about further on. So that's the presentation, but the buzzword presentation for third year, which you guys probably already remember from second year, is severe tearing central chest pain radiating to the back, and it might move over time. So in terms of your investigations, because this is something presenting with chest pain, you always want to do an ECG and troponin, so you want to rule out ischemic myocardial ischemia. And then you also look for other differentials. So amylase and lactate. Does anyone know why you do an amylase? Just yell out. Or a lipase, amylase, lipase. Pancreatitis, yeah, good. So that's one of your differentials. And the best thing to do for these people is you want to do a CT of the chest, abdomen, or pelvis, depending on where you think the dissection is, so you can confirm the diagnosis. The rest of the imaging you don't really need to know. Just remember your CT. Given that I've written gold standard there, just one thing I want you guys to remember this year is you need to know your investigations really well. So the emphasis on third year is doing, having differentials, and then how do you investigate each of those differentials? So if you're thinking pancreatitis, you should know I do an amylase or lipase. If you're thinking AMI, you should be saying I want to do a troponins and an ECG. So in terms of knowing your investigations, there's often a gold standard, which is what you'd ideally want everyone to do. and there's a first line investigation. So if you suspect someone has something, you might do a first line, but you might have a gold standard diagnostic. So in third year, you're really expected to know the difference. So you might do everything listed above there, but the gold standard, the definitive diagnosing test, is a CT. So management we've already talked about. So this year it's more a thing for fourth year, but if you get asked for management, do your symptomatic management. So I'll give them analgesia. You want to lower their blood pressure, remembering blood pressure will worsen the dissection. So you give them IV labetalol or a beta blocker. And the aim is to reduce systolic blood pressure less than 120. For type A dissections, which are proximal to the left subclavian, you take them to theatre. For type B, you just give them antihypertensives and you aim for a blood pressure of between 100 and 110. And that's the management. And prognosis is not too great. 5-year survival of 60%, 10-year survival of 40%, even with treatment. So it's not a great condition to have. Everyone happy with that? Any questions on dissections or aneurysms? Awesome. Let's press on. Cardiac arrest. The reason I bring this condition up, it's not something that I've known has come up a lot in the past, but it is something very interrelated with your BLS, which you're all expected to know inside out, and you do get OSCEs on periodically. So cardiac arrest is basically those rhythms you've learnt in first and second year that you either need to defibrillate or you need to start CPR for. So the four are VT and VF, which everyone seems to remember, asystole, which is a flat line, and pulseless electrical activity, which is where you might have structured electrical activity, but the heart isn't contracting. So these people might have a normal ECG, but they don't have any cardiac output. So those are the four different arrhythmias associated with cardiac arrest. In effect, what we're saying is that the heart doesn't have any cardiac output. So your signs and symptoms are going to be related to that. So they're going to be unconscious because the brain isn't getting oxygen. They're not going to have pulses because there's no cardiac output. And in later stages, their breathing starts to stop, which is right at the end before they die. Cardiac arrests are almost universally fatal unless you do something about it. So in terms of what causes it, there's a whole list of causes. Ischemic heart disease is the most common, but then you also have other things like arrhythmias, heart failure, shock, PEs. There's a whole list. But the important ones to remember are the reversible ones. The reason you want to remember these are because when a patient comes in with a cardiac arrest, if they have one of these causes, you can do something to fix it. So it's memorized by the H's and T's. Apparently there's 4. I found more than 4 every time I've looked at a textbook or online. So I've written every single one I found there, and they're all causes of reversible cardiac arrest. So I just remember it as the H's and the T's. So hypovolemia, you've got low circulating volume. Hypoxia, reduced oxygenation. Hydrogen ion, so you've got a metabolic acidosis. Hyper or hypokalemia. Hypothermia, and then hyper or hypoglycemia. And then for the T, so tablets, which are just a bunch of drugs. Cardiac tamponade, attention pneumothorax. Thrombosis, which is an AMI, which we've said is the most common cause. And thromboembolism, which is a PE. So those are the causes you want to screen for in a patient who's come in with an arrest, because you can do something about it. So in terms of etiology, VF and VT, I'm sure you guys are all familiar with. We'll talk about it in the arrhythmia section, but these ones you defibrillate because you can cardiovert them easily. Asystole, you can't defibrillate. So for these patients, you just keep giving them CPR, you give them IV amiodarone, and you give them IV adrenaline. How much you need to give and in what sort of pattern is something you'll learn in final year. And PEA, again, you can't defibrillate it, so you have to give them CPR along with IV amiodarone and IV adrenaline until they come around. So in terms of management, you've got your basic life support, which hopefully hospitals have drilled into you by now. And hopefully they'll come back. And once they do, you start, or while you're resuscitating them, you want to start doing some quick investigations to look for those reversible causes. So do an ECG, check their blood, check their glucose, check their troponins in case they're having a heart attack, do a chest x-ray in case they have a pneumothorax. And then once these patients have come back, one of the long-term things you need to think about is why did they go into VT or VF, if those were the arrhythmias they went into. And if it's something that you think might happen again, these patients need to go home with the defibrillator. So they need a defibrillator placed in. And that's the advanced life support algorithm. Again, you don't need to know it. Just recognize which ones are which ones you can defibrillate, and which ones of them you need to manage with IV adrenaline and amiodarone. Everyone happy with cardiac arrest? Pretty straightforward. Carotid stenosis is something that I think is a very OSCE examinable station, just because it's one of those great conditions that's not an AMI, so you can filter out those people who know their vascular disease from those who don't. And it's got a lot of stuff in there that's related to OSCEs. So stenosis, hopefully you'll all know by now, stenosis means obstruction. So carotid stenosis is where the internal carotid artery bifurcates. You get turbulent flow because of the bifurcation. So this part of the carotids are prone to atherosclerosis. So in effect, what happens is you get a plaque, as you do in a heart attack. You get a plaque which forms in the carotid arteries. Again, affects males more than females, and your risk factors are exactly the same. So there's a clear pattern with this. In terms of pathogenesis, it's exactly the same. You get a plaque which forms, and then that plaque is vulnerable to rupture. If it ruptures, it can either flick off bits of the plaque into the cerebral vasculature, or alternatively, it can form a clot, and that can completely cut off blood flow in that coronary artery. So your symptoms are basically those of a stroke. It's going to be asymptomatic before. When it does become symptomatic, you're going to get a stroke. So one of the entities that's new this year that you might not have come across is something called a transient ischemic attack. The way to think about it is this is just a mini stroke. So what happens is the plaque ruptures and you get little bits of emboli going into the cerebral vasculature, but they don't cause a permanent occlusion. So you'll get symptoms that resemble a stroke. So they might say, I've got hemiplegia or I've lost vision. But these symptoms resolve within 24 hours. So that's how you differentiate a stroke from a TIA. A stroke is going to have lasting damage. A TIA doesn't cause loss of neurons, and it's going to self-resolve. And almost all of these patients with a TIA are going to be fine in sort of 10 to 15 minutes. So it's very rare for it to be that protracted. But once they've had the symptoms for more than 24 hours, you can start looking at investigating for a stroke, because that's what it's likely to be. So TIAs are, because they're mini strokes, by virtue that means they're a warning sign for a stroke. If someone has a TIA, you're thinking they probably have carotid stenosis. So they have a problem which I need to look at fixing because they're at risk of having a stroke. So that's the importance of a TIA. So as I said, these things are asymptomatic until you either have a stroke or you have a TIA. So a TIA is going to cause symptoms that the stroke would. It's going to mirror the same vascular territory. But the sort of buzzword TIA symptom that you need to know is something called amaurosis fugax, which is basically described by, if you talk to a patient on the wards, go to the vascular ward, find someone who's had a carotid endarterectomy and ask them, they'll say, I was driving along or I was walking along and I suddenly felt like a curtain was descending across my left eye. So that's a transient loss of vision because you're having occlusion of the posterior cerebral artery, which affects the visual cortex. So that's sort of your buzzword TIA presentation. But remember, a TIA is in effect a stroke. It'll present with exactly the same symptoms. It's just that it's reversible. But in an EMQ, if you see someone having a unilateral loss of vision, which came back 10 minutes later, that's amaurosis fugax. That's a TIA. So you've got your diagnosis. It's a TIA due to probably carotid stenosis. So how do you investigate these people? So we've talked about the pathophys of carotid stenosis causing strokes and TIAs being associated with the fact that you're getting emboli going into the cerebral circulation. But it's just as important to check out the heart, because remember, conditions such as valvular heart disease and atrial fibrillation also sends off emboli. So it's really important to do an ECG. And if you're worried about valvular heart disease, so have a listen to their heart, but then do an echocardiogram. You want to make sure that their heart is fine. Do the blood test looking for the risk factors of atherosclerosis, so do an FBE, do a UEC, because if they have atherosclerosis in one place, they probably have it in their renal arteries as well. So check their renal function, look at their lipids, all those sorts of conditions. And another cause of sort of these stroke-like symptoms could be a hypercoagulable state, which is predisposing you to clots. So do a coagulation screen. So look for causes of thrombophilia. In terms of imaging, so this is where it's important to know your two different tests. So the screening test, if you're worried that they've got carotid stenosis, your screening test is a carotid duplex ultrasound. But if the ultrasound shows stenosis and these people need surgery, the gold standard test to diagnose the stenosis is a carotid angiogram. So you stick a catheter up and you inject dye and you look at the contrast to see if there's any sort of occlusion. So that's the two different. So if someone came in with carotid stenosis in an OSCE, you'd say, I'd like to do an ECG, an echocardiogram, look for like any hypercoagulable states, and I'd like to do a carotid duplex ultrasound to evaluate their carotid arteries. If I find stenosis and I think they might require referral, I'll go on to give them a carotid angiogram. So the reason you don't jump straight to the angiogram is because it has a 1 to 2% risk of stroke. So you don't want to expose them to that risk unless you absolutely have to. In terms of management, management is all lifestyle. So if it's asymptomatic for these people, so they might have a carotid bruit, so that might be your first sort of inkling that they might have asymptomatic carotid stenosis. For these people, you treat their risk factors, treat their hypertension, treat their diabetes, give them statins to control their lipid, tell them to quit smoking. So all their modifiable risk factors you need to address. In terms of surgery, for people who are asymptomatic, we don't give them surgery. There's no benefit, and in fact, the risk might exceed the benefit. However, if they have symptoms and their degree of stenosis is more than 70%, and that's a number you need to remember. If stenosis is more than 70% and they're symptomatic, these people should have a surgery. So if they've come in with a TIA or a stroke, give them an endarterectomy because they're at great risk of having another stroke. There's also a new minimally invasive technique where you go up through the femoral vessels and you can stent it, so do an angioplasty, so either balloon dilate it or stent it, which is what you do in an AMI. However, it's got as much risk and less benefit. So these people may as well go and have an endarterectomy. For those wondering what an endarterectomy, do people know what an endarterectomy is, or am I just, okay, you guys can interrupt me and I can answer it. So it's basically an incision down the entire length of the carotid, and they quite literally split the carotids open and they scrape out the plaque. So it's a pretty invasive procedure and it's a pretty high risk procedure. So if you go onto the vascular wards, you might see people with either unilateral or bilateral scars over their carotids. That's what they've had. Okay, so peripheral arterial disease, again, along with carotid stenosis, this is one of the big conditions I would definitely recommend you know. So aortic aneurysms dissections, they might feature on your EMQs. These peripheral vascular disease and carotid stenosis are more OSCE stations. So as you can imagine, if you need to waffle on for 8 minutes, it's probably desirable you know something about what you're waffling on. Otherwise, it can be a very long 8 minutes for you. So peripheral arterial disease, which is what tends to happen on PAT stations, longest 8 minutes of your life. Peripheral arterial disease. So I'm not going to be talking about venous disease in any great amount of detail because it's not particularly high yield. So that's something you guys can go and study in your own time. So all the vascular disease I'm going to be talking about is related to the arteries. So peripheral arterial disease, again, almost always caused by atherosclerosis, and it's got exactly the same risk factors, and it affects men more than women. So as with all the conditions we've looked at so far. In terms of peripheral arterial disease, it can affect any of the arteries. If it affects the brain vasculature, it presents with strokes and TIAs. If it affects the renal arteries, you'll get acute, so you'd get renal failure or hypertension. If it's in the mesenteric arteries, it'll affect your gut. So you'll get gut claudication, which is something that they'll talk about in your GIT lectures. And if it affects the limbs, obviously you can get limb ischemia or intermittent claudication, which is one of those questions you learned in cardio in first year, which is where on physical exertion, they get pain in their legs. So that's how it presents. What we're going to be talking about mainly today is peripheral vascular disease, which affects the lower limbs. So in terms of how this happens, it can either be thrombotic, which is where you've got a plaque, the plaque ruptures, causes a clot, occludes the blood vessel, which is what you'd be familiar with from AMIs, or it can be thromboembolic or embolic, which is the other big one. So embolic versus thrombotic, embolic meaning you've got an embolus which flicks off and suddenly acutely compromises blood pressure. So thrombotic is likely to have a long protracted course with sudden worsening, whereas embolic can be someone who's been previously well and they've got sudden onset of symptoms. So in terms of lower limb arterial disease, which is what peripheral vascular disease tends to be, as we've mentioned, it affects the lower limbs. So it can affect anywhere from the aorto-iliac junctions down into the femoral and the popliteal segments, and even further down below the knee in the infrapopliteal blood vessels. So the way we think about it is it's got two distinct clinical entities. So intermittent claudication, which I'm sure you're all familiar with. Does anyone need a quick revision of intermittent claudication? Everyone happy with? Yeah, so I'm just going to assume you know it. And critical limb ischemia, which is sort of the more severe end of the spectrum. So risk factors we've talked about are the same. The way we classify the severity of peripheral vascular disease is this thing called the ankle brachial pressure index. These are numbers you should remember because it's very relevant for OSCEs. So greater than 1 is normal. However, greater than 1.2 is abnormal because it suggests there's wall calcification. I should have put that in. So maybe make a note of that. Greater than 1.2 is abnormal. You start worrying about arterial calcification. So 1 to 1.2 is normal. 0.5 to 0.9 is intermittent claudication, and less than 0.5 is critical limb ischemia. So this is a spectrum. So when we say ankle brachial pressure index, all we're saying is we measure the pulse, we measure the pressure, blood pressure at the brachial artery and over the ankle, and then we compare the ratio. So that's all it is, a ratio between the two. So as you'd expect in someone with no disease, the blood pressure should be the same at both sites because you shouldn't have atherosclerosis, and the blood pressure throughout the aorta should be exactly the same. So intermittent claudication we've talked about. So it's pain in the leg muscles on exertion. The three characteristic features are pain with exertion, relieved after a short rest, and reproducible by the same amount of exertion and rest. So when someone gives you a history of intermittent claudication, they'll say, I walk 200 meters, I get pain in my buttocks or pain in my calves. The pain goes away after 5 minutes of rest. Then I walk 200 more meters and the same thing happens. So that's your cardinal features of intermittent claudication. These people don't usually need surgery. These people you manage aggressively with lifestyle factors as well as controlling their risk factors. So tell them to quit smoking, give them a statin, control their blood pressure, control their diabetes. And almost all of these people are going to respond to that. But if in 6 months they haven't had a response, you start thinking about surgical intervention. Do we need to give them a bypass? Do we need to stent them? Do we need to give them an endarterectomy? Critical limb ischemia is the severe end of intermittent claudication. So these are people who've had 10 years of intermittent claudication. And then suddenly they're going to say, I've got pain at night in my foot. The pain is there when I'm resting. So there's this definition, which is the technical definition. But the way it's going to present on your OSCEs or when you talk to a patient is they're going to say there's pain at rest, where in intermittent claudication, they were fine at rest. So they're going to say there's pain on rest, and they've got a very characteristic presentation. They'll say, I've got the pain throughout the day, and it's really bad at night. And what I do is, because the pain's so bad, I wake up and I hang my feet off the edge of the bed, and it gets better. The reason it gets better is gravity helps blood reach the distal parts of the lower limbs, so it gets better. But then eventually that benefit stops. They're still ischemic, and they're going to say then the pain came back. So there's that characteristic story of pain at night. I hang my feet off the edge of the bed, and it went away. So that's how you distinguish critical limb ischemia. It's pain at rest, and they're going to require strong painkillers for it. So these patients are really, really urgent to pick up because they need surgery. If you don't give them surgery, almost all of them are going to either die from a gangrenous foot causing sepsis, or they're going to require an amputation. So there's morbidity and mortality associated with critical limb ischemia. So these people need to go to theatre. You need to give them a bypass, an endarterectomy, or you need to stent them, whichever the vascular surgeon decides is the best. So obviously, if they're 90 and they have 1,000 other conditions, you can either choose to palliate them, or you can give them the minimally invasive. Whereas if they're 50, you may as well give them the bypass. It's a bigger surgery, but they're more likely to put up and cope with it. So in terms of your buzzword, we've talked about your symptoms, which are your critical limb ischemia and intermittent claudication. Your signs are really important to rattle off in an OSCE. So if you open up Tally and O'Connor, which I know a lot of people didn't look at in pre-clin, that was me as well in pre-clin. Tally and O'Connor actually has a whole chapter on peripheral vascular disease. So it's an entire exam on its own with lots of specific examinations. I'm not going to be talking about that today, so I'd highly recommend go home in your own time and have a look at it. It really talks about the different types of ulcers, how to examine someone with arterial disease, what sort of signs and symptoms you affect. But in a nutshell, what you're going to expect is because of atherosclerosis, they're going to have diminished or absent pulses distally. So you're going to feel their dorsalis pedis, it might not be there. They might not have a posterior tibial, but you might feel a popliteal or a femoral. So you keep going up until you feel a pulse. They're going to have hair loss. They might have ulceration or gangrene. Their nails are sort of dry, thinned, and brittled. Their toes might be cyanotic or gangrenous. And then there's this characteristic thing called Berger's sign, which is a test you do in the examination where you lift up their leg. Now, if you lift one of, assuming none of you guys have peripheral vascular disease, if you lift up your legs, your feet and legs should stay the same color. It should have no impact. But in someone with peripheral vascular disease, when you lift their leg, because they've already got that stenosis, the heart actually can't pump any blood into the distal extremities, so their foot goes white, and then when you hang their foot off the edge of the bed, it suddenly goes red, because gravity allows the blood to rush back into the foot, so you get a reactive hyperemia. So that's what we call Berger's sign. In terms of investigations, you'll notice a theme. You're screening them for risk factors, so you do a fasting metabolic profile, so look at their blood sugar levels, look at their lipids, check their blood pressure, do a full blood exam, do the ankle brachial pressure index. That's your buzzword for what investigation you do in chronic lower limb disease. And then you can take them for imaging. So you can give them an angiogram, so either a CT angiogram or an MR, or which is like an angiogram with an MRI. You can give them an ultrasound, or you can give them an angiography, an arteriography. Treatment is, again, exactly the same. I'd highly recommend you memorize this treatment because for all these vascular conditions, treatment's exactly the same, barring the specifics for that condition. So for all of these people, you want to treat their risk factors, tell them to quit smoking, control their blood pressure, exercise, diet, all of the Craig Hassard stuff. But then the sort of specific things you want to do is you want to tell them to look after their feet. They've got reduced circulation, meaning they're prone to getting ulcers, and those ulcers aren't going to heal, and they might need an amputation if it becomes gangrenous. So tell them to see a podiatrist, tell them to look at their feet. In terms of medical, you've got peripheral vasodilators, which I don't know if you need to know, but I mean, they're mentioned on ETG. So cilostazol is one of those peripheral vasodilators, which you can chuck in for your honors on your OSCE. And surgical wise, we've talked about the options. So it's the same for all of these. You can either bypass them, you can give them an endarterectomy, or you can stent them or give them an angioplasty, which is just a balloon dilatation. And if the foot's not going to get any better and you know it, you may as well offer them an early amputation as opposed to letting it get gangrenous, because they're going to need to lose it eventually. It's better that they lose it when they're systemically well rather than when they're septic from a gangrenous foot. In terms of prognosis, intermittent claudication, if you just do your lifestyle stuff and control their risk factors, 60 to 80% improve. So as you can see, that's in sort of that reversible phase. But once you hit critical limb ischemia, a lot of them are going to either die from sepsis from a gangrenous foot, or they're going to have an amputation. Or the other thing is, if you have atherosclerosis in your lower limb arteries, you probably have atherosclerosis in your carotids and in your heart. So these people are at a very high risk of having an AMI or a stroke. So for any of these conditions, if they've got one of them, they've probably got others, which may be asymptomatic or have subclinical presentation. Upper limb arterial disease is something that was just in the textbooks. You don't need to know about it. But basically, it's atherosclerosis of the subclavian arteries, and it presents with the same sort of stuff. They might get claudication of the arm, or they might have the plaque rupture and it flicks off little emboli, and the emboli will lodge in your digital arteries and they lose the finger because they've lost blood supply to the finger. And again, treatment is the same, but this is very rare. So it's probably something you don't need to waste your time knowing. Acute limb ischemia is the opposite end of the spectrum. So we've been talking about stuff that's been going on for 20, 30 years. So it's been a while in the making. Acute limb ischemia is the exact opposite. These are people who present very acutely with sudden onset limb pain because their vascular supply is compromised. So in effect, it's occlusion or rupture of a peripheral artery, and it'll cause rapid muscle loss, necrosis, and gangrene. So it's a medical emergency or surgical emergency, and you need to fix it quickly. So the causes, there's two causes. You can either have embolic disease, which is where they might have atrial fibrillation, they might have infective endocarditis, they might have valvular heart disease, and an embolus flicks off from their heart and decides to go down the subclavian artery, and they get acute limb ischemia of their arm. In contrast to thrombotic disease, which are people who might have peripheral vascular disease, but then the plaque ruptures and the thrombus is so big that it blocks off the artery. So obviously embolic has a very dramatic presentation because these people are previously well. And also, if you imagine having a bit of stenosis over time, you're going to get collateral blood vessels forming. So alternate blood vessels which supply the same vascular territory. If it's an embolus, there's been no time for this collateral supply to develop, and you get sudden severe onset of symptoms. So how do you remember the clinical presentation? There's the 6 Ps of acute ischemia, which are the same as the 6 Ps of compartment syndrome, which you guys did in first year PBLs. So pain, pallor, pulselessness, perishingly cold, paresthesia, and paralysis. So these are all signs and symptoms to look out for. They're not very accurate, but it's an easy way to remember it because people have different pain thresholds. If they have pulselessness, it's a very, very late sign, not good. If they have paresthesia and paralysis, again, they're probably about to lose the limb. So it's not ideal in terms of understanding its presentation, but it's a good way to remember it. How do you investigate it? Do an ECG. You want to rule out atrial fibrillation because remember, that's your embolic cause. Do troponins because you want to make sure there's no underlying cardiac pathology, and then you give them an angiogram. So really, you want to take them for an angiogram because that's what's going to give you a definitive diagnosis of occlusion of that blood vessel. So these people have 6 hours till they lose their limb or lose function in their limb. So these people need to go straight to vascular surgery. In terms of the management, give them heparin and then try and work out, is it embolic versus thrombotic? If it's thrombotic, you treat them as you would treat an AMI. You give them heparin, you give them antiplatelets, you give them statins. So it's trying to get rid of the thrombus. As opposed to embolus, which is sudden complete occlusion, which you'll recall is more dangerous because there's no collateral supply. These people either need thrombolysis or they need to have a thrombectomy or an embolectomy where you go and pull out the clot. So you need to work out what it is pretty quickly because that's going to determine your management. And for all of these patients, once they've had one of these episodes, you need to give them heparin and warfarin long term until you work out what the cause is. If they're in AF, try and fix their AF. If it's going to be persistent AF, obviously you can't do anything about it, so you leave it be. Just an interesting thing that I learned last year was this thing called reperfusion injury. So there's a lot of recent evidence which suggests that in people who have had occlusion of blood vessels, if you suddenly go and perform thrombolysis or a thrombectomy or an embolectomy or you stent it, basically all the toxic metabolites which have been building up from the ischemic tissue can flood the bloodstream. And that can cause problems. So it can affect your kidneys, which is the classical presentation. They present with acute kidney injury. So it's just something to keep in mind. In terms of complications, if they've lost their limb and it's gone gangrenous, they might have multi-organ failure with sepsis. They might lose the limb. They need amputation. Or they can get compartment syndrome, which again is one of those conditions you talked about in pre-clin. And prognosis, it's got a pretty significant mortality morbidity rate. So need to pick it up fast. Won't go through this. The only reason I've put this in here is because I know on EMQs, Berger's disease in particular is an option which pops up. So it's good to have an idea of what it is. So it's an inflammatory arterial disease, and your buzzwords are it's going to be in a young male smoker. So it basically destroys your arteries, and unless you quit smoking, you're going to lose your limb. So it's just a differential diagnosis to be aware of. Obviously, it's probably not going to be an EMQ, but if it is an option, it's worth knowing what it is. So it's not atherosclerosis, it's an obliterative disease which affects young male smokers. So treatment is with smoking cessation. Raynaud's phenomenon, I'll leave to Nikki. It's more of a rheumatological thing. Basically, it's vasospasm of your digital arteries, and it causes a characteristic color change. So you lose blood supply, so your fingers go white, then they go blue because they're ischemic, and then there's reactive hyperemia as the vasospasm relieves itself. So that's very related to rheumatology, so that's probably going to be covered there. All right, ischemic heart disease. So we'll hopefully finish this in 10 minutes and you guys can have a break. The second part of this is a lot easier because this is where most of your OSCE stuff lies. Ischemic heart disease, I'm sure you all know a little bit about ischemic heart disease in some depth. But in terms of classifying it this year, there's actually a very complicated classification system and you do need to be aware of it. So have a look at this flowchart. So you've got ischemic heart disease, which is your broad, basically atherosclerosis of your coronary arteries. Now, we classify what that causes based on the different clinical syndromes which atherosclerosis of the coronary vessels causes. So coronary heart disease or ischemic heart disease can get divided into stable angina or acute coronary syndromes. Acute coronary syndromes are the more emergent end of the spectrum. These are what arise when you get sudden occlusion of the coronary arteries, whereas stable angina is where you've got a small degree of stenosis and it's pretty constant. So acute coronary syndromes are what is basically what happens when that plaque ruptures and you get a variable amount of occlusion. So we can divide acute coronary syndromes into STEMIs, which are ST elevation myocardial infarcts, or non-ST elevation acute coronary syndrome. So non-ST elevation coronary syndromes are non-STEMIs, so non-ST elevation, and unstable angina. So each of these conditions now has a different definition, which is a bit of a pain, but you need to know it. So we'll talk about each of these in turn. So I'm not going to talk about pathology, but I chucked a bit on because I understand your pathology assessment is actually summative this year and you've got exams or quizzes of some description. So I think you guys have a path lecture coming up in a month or so. So this will probably be touched on in a lot more detail there. But just in a nutshell, ischemic heart disease, almost all of it is caused by atherosclerosis, but it's important to remember there can be other causes as well. So ischemic heart disease, we're basically saying the myocardium does not have enough oxygen. That's the definition of it. Ischemic, not enough oxygen. And we're only really interested in the myocardium because that's what's pumping the blood. However, you can, if you think about other causes of myocardial ischemia, depleting it of oxygen because there's stenosis of the coronary arteries is obviously one. But in conditions where there's increased demand, so there's greater amounts of myocardium, or they're constantly tachycardic, so in conditions like thyrotoxicosis, these are conditions where your myocardium needs more oxygen, and even though your coronary arteries are fine, you're still getting ischemic myocardium. So you're getting those symptoms. Similarly, if you've got diminished blood volume, there's not as much blood perfusing the myocardium. If you've got diminished oxygenation because your lungs are cooked, you're going to get, again, ischemic myocardium. And if you have low hemoglobin availability, be that due to anemia or carbon monoxide poisoning, again, you'll get ischemic myocardium. So important to realize that ischemic heart disease is almost by and large caused by coronary artery atherosclerosis, but it can also be caused by other things, which are uncommon, but you should know that they exist. So what is atherosclerosis? Progressive inflammatory disorder characterized by the presence of atherosclerotic plaques in the innermost layer of the coronary vessels, which is your tunica intima. And basically they're composed of cholesterol and necrotic debris. And they're covered over the top by a fibrous cap. I've got a picture in the next slide. Your risk factors are exactly the same. You've got your non-modifiable risk factors, family history, age, being male, and you've got your modifiable risk factors. Do you smoke? Do you have high blood pressure? What's your lipid like? Do you have diabetes? One other systemic risk factor that I want to talk about is systemic inflammation. The reason I mention this is in patients with inflammatory diseases, so conditions such as rheumatoid arthritis, these people have a life expectancy of less than 10 years. Now, I can tell you that their joints are stuffed up, but with modern medicine, they don't have joint damage. So it's not their joints which kill them. But because these people have an autoimmune disease, they have systemic inflammation, they have inflammation of their coronary vessels, which predisposes them to atherosclerosis. So people with rheumatoid arthritis, on average, live 10 years less than people who don't. And the reason for that is systemic inflammation. So it's important to recognize that in people with all your weird rheumatological diseases, they have systemic inflammation, so you really need to look after their heart and their kidneys and their carotids, obviously. So picture of a plaque. So in terms of the classifying a plaque, you can say if it's stable or vulnerable. Vulnerable means it's got a thin cap. So the lipid here is highly thrombophilic, thrombogenic. So if the cap ruptures, the lipid core is exposed and your platelets aggregate and cause a clot. That's how you get your myocardial ischemia. If you have very little lipid and a thick fibrous cap, as you can imagine, it's less likely this is going to rupture. So these people are less likely to have coronary, acute coronary syndromes. So it's important to recognize this, and there's a lot of research into trying to find ways to determine how many of these people, because at our age, almost all of us have fatty streaks already. So you've already got the beginnings of atherosclerosis. So there's a lot of research trying to determine which of the people with these plaques are likely to rupture. So there's your anatomy. Again, I'm going to leave this up for you to look at, and hopefully in your path revision lecture, it's gone through in a bit more detail because it's important to know. Lots of text on this slide. Again, it's all pathology. Basically, it's saying exactly what we've talked about. You've got a plaque. If the plaque ruptures, the lipid cause platelets to aggregate and you get a clot. The clot cuts off blood supply to your myocardium, you get a heart attack, or you get ischemic chest pain. And that's basically all that says. This is interesting. I don't know how relevant it is, but if you pick up any of the path textbooks, it seems to really emphasize this. So we've talked about there being two types of AMIs. You've got your ST elevation and your non-ST elevation. The pathological difference that they believe results in ST elevation versus non-ST elevation is that in ST elevation, they believe that you get transmural infarction, meaning the entire wall of the ventricle is ischemic and dies. So that causes ST elevation. In contrast to non-STEMIs, where they think it's a subendocardial infarction, meaning only a part of the wall of the heart dies, so you don't get that characteristic ST elevation. And then there's a third entity, which are microscopic infarctions, which is what you get with coronary vessel spasm. So you can get coronary vessel spasm with things such as using cocaine. So the pathological buzzword here is once myocardium becomes ischemic and dies, it undergoes coagulative necrosis. So it's really important, and I'm sure it'll be talked about in path, but go through your different types of necrosis. So brain has liquefactive necrosis. Basically everywhere else in the body has coagulative necrosis. And the one that everyone seems to remember, caseous necrosis, that's what happens when you have TB. So go through that. Memorize this table. It's accessible. So one of those things to cram sort of the night before your first exam, know what the macroscopic and the microscopic features are. And I know it's in your path quizzes because it was on ours, and it's very accessible. So definitely worth knowing. And if you're unfortunate, I could probably see them giving you a macroscopic specimen of a heart. And they might ask you, how long do you think it's been since the heart attack? The important thing to note though, once you hit sort of more than 2 months, you can't work out how old an infarction is because the fibrosis or scarring process is complete. The ventricular myocytes have remodeled. So there's no way to say whether this happened 6 weeks ago, 6 months ago, or 10 years ago. Just something to keep in mind, but do memorize that. Don't worry about the electron microscope findings. You don't need to know that, but know your macroscopic and microscopic features. So let's quickly talk about this stuff. Stable angina, it's basically intermittent claudication of the heart. That's how you should think of it. So it's stable because these people are going to have those characteristic 3 features. I go for a walk, I walk 200 meters, I get crushing retrosternal chest pain, which by now I'm sure you've all worked out is ischemic myocardium. That's how it presents. I get crushing chest pain. I either take nitrates, so a spray under the tongue, or I sit down. I sit down for 10 minutes, it's gone. I walk 200 meters again, and it happens again. So stable angina is exactly that. Angina, chest pain, stable. It's stable in the amount of pain, the character of the pain, and how quickly it gets better and what makes it better. So again, more common in men, identical risk factors to what we've talked about. So basically, we've talked about these three. So the things which can precipitate it are exertion, emotion, and eating. Also, there are some people who get angina when lying flat, which is called decubitus angina. The characteristic is, as with intermittent claudication, these people will rest and the pain will go away. Or they'll take nitrates, which you remember from pharmacology are your vasodilators. They'll take nitrates and the pain will get better. So in that sense, it's stable. You need the same amount of exertion or stimulus to make symptoms appear, and it'll go away with exactly the same stuff. Presents exactly like an AMI. The only difference is it goes away. So it presents with retrosternal chest pain. They might be sweaty. The pain may radiate to the left shoulder and neck and jaw. They might have nausea. They might have anxiety. It's exactly the same presentation. For all of these, for stable angina and all the acute coronary syndromes, the presentation is identical. The only difference is how quickly do the symptoms go away, or how did the symptoms come on. So in stable angina, they had a stimulus. In contrast to a myocardial infarction, but they'll often just be at rest. Yes, exertion can make it worse or precipitate it, but classically, it'll be someone who was asleep or sitting on the couch or doing the dishes in the kitchen and they got chest pain. So there was no stimulus for it. In terms of your investigations, ECG, you want to make sure it's angina and it wasn't an AMI, and then look for their risk factors. And then the buzzword test you want to do is you want to do troponins, which are your cardiac enzymes, which we'll talk about in a bit, to exclude an AMI. Once these people have angina, you want to evaluate what their heart function's like. So these people, you might give them an angiogram to work out what the degree of stenosis is, or you'd start off with simpler tests. Make them run on a treadmill and do an ECG. See if there's signs of ischemia on the ECG. Or make them run on a treadmill and do an echocardiogram, or an ultrasound of the heart, to see if there's any changes consistent with ischemia. Management, again, lifestyle, we've talked about all of that already. But for symptomatic relief, these people respond well to GTN. So what you do is you have one spray every 5 minutes and you repeat that 2 times. If the pain doesn't get better, take it a 3rd time, call the ambulance. Because if you think about it, if they've had 2 sprays, it's already been 10 minutes. If after 3 sprays they haven't improved, it's been 15 minutes, which is that cutoff for angina. So you start thinking about, is this a heart attack? In terms of preventing the angina episodes, you can slow the heart rate so the myocardium isn't as stressed, so you can give them beta blockers. And this year, it's important for you to recognize the different types of beta blockers. So there's beta blockers which are more cardioselective. So the ones to remember which are cardioselective are atenolol, metoprolol, and bisoprolol. And the other set of drugs you can give them are calcium channel blockers, but this is second line. So you again need to remember the different types of calcium channel blockers. So you've got the dihydropyridine, which are your peripherally acting calcium channel blockers, which are nifedipine and amlodipine. And you've got your non-dihydropyridine, which is centrally or cardiac acting, which are diltiazem and verapamil. So it's important, you can't just say calcium channel blockers anymore. They'll say which one. You can give them long-acting nitrates, but you need to make sure that they have at least 6 to 8 hours a day when they're not using their nitrates, because they can get resistance to the nitrates. And there's a new drug which actually works on the sinoatrial node to slow the heart rate, which is called ivabradine. These people have atherosclerosis in their coronary arteries. So for these people, you need to make sure you give them anticoagulation in the form of aspirin and clopidogrel, one or the other or both. And then give them an angiogram if their symptoms persist and get worse. And then you can think about either giving them a bypass or angioplasty. So that's it for stable angina. Variant angina are only mentioned because it might come up as an option on your EMQs. Basically, this is myocardial ischemia, but there's no atherosclerosis. It occurs because there's vasospasm of the coronary arteries. So treatment is with long-acting nitrates and calcium channel blockers. If you just know what it is and how you treat it, that's more than enough. Don't worry about this. Acute coronary syndromes. So remember, we've talked about stable angina. Now we're going to talk about acute coronary syndromes, which we divide into ischemic or non-ST elevation acute coronary syndromes, which is made up of both unstable angina and a non-STEMI. So acute coronary syndromes is the umbrella term. We've talked about this. So now to define what a myocardial infarction is. So a myocardial infarction, you need two things to diagnose it. You need serum cardiac markers. So this is stuff like your troponins. These things are released when your myocardium is ischemic and breaks down. So it releases enzymes within the myocytes into the blood. So you need a rise in your troponins and you need changes in your ECG. So to differentiate between the two types of AMI, you've got your STEMIs and non-STEMIs. Both of them have a rise in troponins. But in a STEMI, you get ST elevation. In a non-STEMI, you don't get ST elevation. One other catch is in a STEMI, you might also get a new onset bundle branch block, which is important to remember. So there may be ST elevation, but a new onset bundle branch block is also diagnostic. So that's your myocardial infarction, STEMIs and non-STEMIs. The third entity we talked about was unstable angina. So unstable angina is exactly the same as stable angina, the only difference being the presentation. So remember we said stable angina, symptoms are reproducible. The same things cause the symptoms. In unstable angina, these people are sitting at rest and they get chest pain, or their pain lasts longer, or their pain comes on more suddenly, or their pain isn't relieved as significantly by GTN. So it's not predictable, it's different. And that's why it's classified as an acute coronary syndrome, because the level of obstruction in the coronary arteries is dynamic. So it's almost mirroring an AMI, but it's not, because the symptoms will still go away after 15 to 20 minutes. So for people with unstable angina, to differentiate it, they might have ECG changes that are non-specific, but importantly, there's no rise in troponins. So if there's no rise in troponins, and they said, my pain came on suddenly at rest, you can pretty confidently say it was probably unstable angina, and it'll get better itself. So we've talked about unstable angina. So treatment, you need to know treatment. So the first line for preventing episodes of angina are beta blockers. And if beta blockers are contraindicated, so remember contraindications are things like asthma, you can give them a centrally acting calcium channel blocker. So they're slowing the heart rate and they're working to reduce oxygen demand of the myocardium, which improves symptoms. Eventually though, you need to treat this because it's a dynamic process as opposed to a fixed obstruction as in stable angina. You need to give these people treatment as you would treat a heart attack. So give them anticoagulation, give them antiplatelets, treat their blood pressure, treat their hyperlipidemia, and then give them nitrates for symptom control. And eventually, with these people, you can offer them revascularization. So you can say, I can give you a bypass or I can stent you. So we've talked about the presentation for all of this spectrum of conditions being the same, with the severe crushing retrosternal chest pain. The one catch I want to highlight to you is diabetics. Diabetics are weird. So remember, your heart is innervated by autonomic nerves. Diabetics have autonomic neuropathy. So they might get silent myocardial ischemia, or it might present in a weird way. So it might not be your classical presentation. So beware of diabetics. In terms of your symptoms, symptoms are either related to cardiogenic shock or acute heart failure, which is the next part of the talk, or they're related to sort of, signs related to the symptoms. In terms of investigations are, again, similar. Do their blood pressure. You want to make sure if they're having a heart attack that they're not in cardiogenic shock. And do an ECG. You want to make sure, is it a STEMI? Is it a non-STEMI? For bloods, the most important thing is you need to take some cardiac enzymes. So troponins are the ones used most commonly in hospital. The reason we prefer troponins over CKMB, which is creatine kinase specific to the myocardium, is CKMB goes up really quickly, but it also comes down really quickly, as opposed to troponins, which go up quickly, but then they stay elevated for up to a week before they come down. So you've got a longer window to pick up on the troponins. The really important thing about troponins is doing one troponin is not enough. So if a nudge came in and had chest pain, I did troponins, it's elevated compared to normal. That doesn't tell me anything. What I'm looking for is doing troponins 8 hours later and seeing a rise in the troponins. So the rise in the troponins is what's pathognomonic, not an isolated raise in troponins, because that can be caused by 100 different things. You can also do other things, but again, do a lipid profile at some point. You want to look at their risk factors, check their blood pressure, check their blood sugars. So you need to know if they have risk factors which need modification in the future. If you do imaging, imaging's not really necessary, but if you do an echocardiogram, you might see the myocardium is non-contractile because it's dead. And if they have cardiogenic shock, which is acute collapse of the circulation, they might go into acute pulmonary edema, which is something we talk about in heart failure. Hopefully you guys are familiar with the changes on ECG. There's a summary for you. These are how you diagnose it. So it's basically summarizing what we've talked about. So a STEMI is characterized by a rise in troponins and ST elevation or a new bundle branch block. A non-STEMI are non-specific ST changes with a rise in troponins, and unstable angina are non-specific ST changes or a normal ECG with no rise in troponins. So the troponins come back normal. And make sure you go through which leads are inferior, anterior, lateral, posterior. The only one I'm going to mention there is for a posterior infarct, remembering your ECG lead placement, it only goes up to the lateral chest wall. In people with a posterior infarction, because there's no such thing as posterior leads on a standard 12-lead ECG, they're actually going to get reciprocal ST depression in the anterior leads. So you might look at the ST segment and it's going to be depressed in the anterior leads. So something to watch out for. Management for acute coronary syndrome, so STEMI, non-STEMI, and angina, unstable angina, really simple. So the first thing you want to do is resuscitate them. Are they hypotensive and tachycardic? Give them some fluids, stabilize their breathing. So basically your BLS, doctors ABCD. And then the mnemonic to remember how you treat them is Monash. So morphine, so analgesia, high flow oxygen, but you only give oxygen now if there's evidence of hypoxia. You don't give it if they're well. In the past, they used to just chuck on high flow oxygen. Turns out that it's actually detrimental and it causes more damage than good in someone who's got normal blood oxygen saturations. Nitrates, so symptomatic relief, it's a vasodilator. Aspirin, 300 milligrams crushed orally, so they just swallow aspirin. Now, S is streptokinase. So streptokinase was an old thrombolytic they used, which used to break down the clot in the coronary vessel and used to lead to reperfusion. Basically, the S is saying reperfusion therapy. We're trying to get blood circulation back to the ischemic myocardium. So we don't use streptokinase anymore, which was a type of tissue plasminogen activator, TPA. We now use retoplase, tenecteplase, or alteplase, which I've got written down in the next few slides. Or for a STEMI, the ideal intervention is percutaneous coronary intervention, where you put a catheter in the groin and you stent the vessel. And H is heparin. So all these patients need heparin and anticoagulation. STEMI, as I just said, is a medical emergency. Remember, these people have transmural infarction, so the entire wall is dead or dying. So these people, you need to try and revascularize it quickly. So hopefully you can save some myocardium. So you either give them a stent or balloon dilatation via PCI, which is an angioplasty, or you give them thrombolysis. What you choose is dependent on a number of things. Firstly, if it's been more than 12 hours since they had the STEMI, there's no benefit to giving them any of those. The myocardium's already dead. So it needs to be less than 12 hours for you to consider this. Now, if it's, so you've got targets, you don't need to know what the targets are. That's just there to give you a rough idea of how urgent it is to give them definitive treatment. But if you can't give them PCI in 2 hours, you give them thrombolysis. So if you're in a peripheral hospital and it's going to take 3 hours for them to be brought in by a helicopter to Melbourne, that's too late. So you give them thrombolysis. So your cutoff is less than 12 hours to give them something, And if you can't offer them a cath lab with reperfusion via PCI within 2 hours, you give them thrombolysis. So you give them IV alteplase, retaplase, or tenecteplase, which is your tissue plasminogen activator. For all of these patients, you have to give them heparin, and you need to anticoagulate them long-term, which we'll talk about in long-term management. Now, I've given you a list of contraindications to thrombolysis. It's a very easy station on an OSCE. No 3 or 4 contraindications for thrombolysis. So some of the big ones are, have they ever had an intracranial hemorrhage? Have they had recent major surgery in the last sort of 3 to 4 weeks? Have they got a known brain tumor? Just memorize some big common ones so that if you get it as a question on your OSCEs, you've got stuff up your sleeve. Non-STEMI management of ETG is incredibly complicated. So you sort of stratify them into high risk, intermediate risk, low risk. Basically, you treat them with the stuff you have treated everyone with everything up. You treat them with the same stuff you've treated them up to now. Give them antiplatelets, so give them aspirin and clopidogrel. Give them anticoagulants, so give them heparin. Give them beta blockers, give them ACE inhibitors, give them statins. So the same drug, the cardio drugs we've been talking about till now, just give them that. It's not a medical emergency, but these people will probably need revascularization. So they might need an angiogram with a bypass, or they might just have an angiogram and have it stented at the time. Long-term management, that's off ETG. That's off ETG. Memorize that if you will. I just remember SARB-C, which is a mnemonic like Monash. So SARB-C is a list of all the drugs which have been proven to give mortality benefit. So if you give people these drugs, they're less likely to die. So SARB-C stands for a statin, ACE inhibitor, aspirin, beta blocker, and clopidogrel. So if you just memorize that, you need to give all of these patients these drugs. And as you can see, these are exactly the drugs we've treated them with. ACE inhibitor, statin, beta blocker, and antiplatelet therapy. Everyone happy with that? So that's the management for long term. There's lots of complications post-MI. There's a mnemonic that some people use. This was a question that one of the tutors at the Alfred literally asked me like 6 times last year. I don't know why he had such an obsession with it, but you know, he just asked it again and again. So the common complications are arrhythmia, congestive cardiac failure, shock, and recurrent AMI. There's a whole lot of other ones: pericarditis, aneurysm, cardiac rupture. Uncommon. So arrhythmias, this is why CCUs exist, coronary care units, because they're on telemetry, so they don't get an arrhythmia. Heart failure, shock, so cardiogenic shock, so sudden compromise of the circulation, and they might have a reinfarction. A bit about prognosis. So some questions. So I don't know how you guys want me to do it. Do you want me to like work my way across the room, or? Okay, I'll just work my way across the room. Do you want me to start at the front or the back? Front sounds like the overwhelming. So question 1. So I wrote these questions with your end of year exam in mind. So if you don't know them, it's completely fine. And ideally I'd written them to hopefully stimulate a bit of discussion. So have a read of that. Tell us what you think. You can phone Gus for help if required, because I know he's seen this question. All right, so what are you guys thinking? So he's had chest pain since waking 3 hours ago. What sort of things are you thinking about? What are your differentials? Forget the options. I've just told you someone's had chest pain which came on at night, suddenly 3 hours ago. What's at the top of your list? Acute coronary syndrome, fantastic. Anything else? This is a cardiac lecture, so acute coronary syndrome is good. Now, acute coronary syndrome is 3 separate conditions. What condition does this sound like? So I'm telling you, there's ST depression. It's not responding to GTN. So what's that making you lean towards? Unstable angina. Anything else if GTN isn't working? Yeah, so any of the ACSs. So GTN isn't working, but would unstable angina respond to GTN? Did we say it responded to GTN?
It can, but then it cannot.
Yeah, usually does though.
Yeah.
Usually does. Now, ST depression and initial troponins were normal. So if there's ST depression, what can you rule out from the acute? It's not a STEMI, right? So you're left with unstable angina and a non-STEMI. And initial troponins were normal. So what do you think this is? No, that was the catch. So it's an acute coronary syndrome. I know it's a weird way because I've said STEMI and I've said unstable angina and then I've said acute coronary syndrome. That was actually how, if you look through some of the released papers, they've actually given all three options. So it's a really weird question. The correct answer here was non-STEMI, which is why you go for acute coronary syndrome. So the reason it's a non-STEMI, glycerol trinitrate would usually work. And remember we said unstable angina will go away in 15 to 20 minutes. This is someone who's had pain for 3 hours, abnormal. No response to GTN, again, abnormal. ST depression, you know it's not a STEMI. So now it's either unstable angina or non-STEMI, but you're sort of thinking non-STEMI. I've deliberately chucked in initial troponins were normal because remember I said troponins are useless until 6 to 8 hours later when you do the next set. So you need to see a documented rise. So that's the reason it's a non-STEMI. And non-STEMI is not an option because I took some of the options out of one of those Monash exams that they've released, and acute coronary syndrome was the answer. Happy with that? Yeah, I know it was a trippy question, but all right, you pretty much answered this. So actually, you didn't answer this one at all. So 60-year-old man with long history of stable angina precipitated by exertion or stress presents to the ED with a 15-minute history of crushing central chest pain, which started while he was asleep. ECG and initial troponins were normal, and the pain responded to GTN.
So I'm thinking S3 angina.
Good. Yeah, good. So you know it's a stable or unstable. What strikes you as being abnormal in this presentation? So if it was stable, how would he have presented? Okay, so the key is the pain started while he was asleep. So his pain has started while it's at rest. So what does that tell you it is? It's unstable angina. Good. So the key here was responded to GTN, went away in 15 minutes, probably an angina, but remember we said unstable angina is when it happens at rest or there's a sudden change in symptoms. So unstable angina. Everyone happy with that? Okay, third question. 20-year-old male, you guys would love this one, with arachnodactyly and a palatal abnormality, presents to the ED with sudden onset severe chest pain radiating to the back. He has weak radial and femoral pulses and a different blood pressure on each arm. There's like 1,000 buzzwords in that. Aortic dissection. Is everyone happy with why that's aortic dissection? Yeah, he's got Marfan's. So you literally probably only know one palatal abnormality, which is a high arch palate, which is Marfan's. You know, there's cleft palate and stuff as well, but we go to Monash, so it's only really high arch palate. So how do we classify aortic dissection? Do you remember? Stanford A, Stanford B, and what's the what anatomical point do we use to?
So it's
good. It's surgical because it's a Stanford A.
And then Stanford B is
after the left subclavian. Perfect. Easy. 46-year-old non-smoker presents to ED with acute onset pleuritic chest pain, shortness of breath, and decreased exercise tolerance. Pulse ox shows SATs of 87%, afebrile, rest rate of 30 breaths per minute, and he's tachycardic. His chest is clear to auscultation with no calf tenderness. ECG shows sinus tachycardia with right axis deviation and right fundal branch block. Cheryl. I think you've seen this question as well, but. So pleuritic chest pain, what does that make you lean towards? Yeah, good. So non-cardiac pathology. So you can cut everything related to the heart and aorta. So then the SATs are low. So what does that tell you? Where do you think the problem is if the sats are low and it's not heart related? In the lungs, great. So you've narrowed it down to lung pathology. Now what do you reckon it is? Correct, pulmonary embolism. So the no calf tenderness, classic throw off, only about 30% will have a palpable DVT. Everyone else, you can remember you can get a DVT in your iliac vessels. You can't see that, you can't feel that. So you can get a pulmonary embolus, and your buzzwords on ECG, so you've got the S1Q3 T3, which will be talked about in the rest lecture. But the most common signs by far are sinus tachy, followed by right axis deviation and right bundle branch block. So those are all buzzwords for a PE. 25-year-old male presents with sudden onset blackening of all his toes on the left foot. He had rheumatic fever when he was in his teens. The pulse is irregularly irregular. A diastolic murmur is audible in the left mid-chest. Ignore the murmur. It's not really going to help you too much with this. The left dorsalis pedis and posterior tibial vessels are normal. The toes of the left foot show darkening at the tips. What's the most likely diagnosis? Next person along. Peripheral vascular disease. Why do you reckon it's peripheral vascular? It's in the toes? Okay. So, irregularly irregular pulse. What does that mean to you? Yeah? Any condition in particular? Any irregularly irregular pulse? Sorry? No. So atrial fibrillation. So irregularly irregular pulse is a buzzword for AF. And what sort of things do you associate with AF? What's the risk with AF? Clots. So their atria aren't empty, so they get clots, and the clots can flick off. So this person's got AF, and the most important thing here, he's 25 years old. He's young. He's been well. He's got sudden onset blackening of his toes. Now, the other reason it's not peripheral vascular disease is his dorsalis pedis and posterior tibial vessels are normal. So basically, all of this is suggesting that it's not peripheral vascular disease, and he's probably got an embolus because he's got atrial fibrillation. So out of that, now that we've gotten rid of peripheral vascular disease, what do you reckon it is? It's all right. This is a tricky question. And it's on one of the Monash exams that got released. So it's a Monash question. He's got AF. Have a look at the options there. Which one of them correlates with AF? Just an embolus. Yeah, that's exactly it. So it's an embolus. Now, this is in contrast to this question, which I'll go through quickly, just in the interest of time. 45-year-old male presents to the clinic with blackening of the great toe over 2 weeks. It's gotten worse gradually. He gives a history of intermittent claudication. His examination is normal, but he's got nicotine staining off the nails and teeth, meaning he's a smoker. On examination, you can't feel his right dorsalis pedis and posterior tibial vessels. So he's obviously got atherosclerotic disease in his lower limb vasculature. The right great toe is gangrenous. So this is someone who's had a protracted course. They've got a history of intermittent claudication. It's a gradual presentation, which leads you to peripheral vascular disease. So that's how you separate the two. Embolus, young person, bang, just happened. They've got AF or they've got some other sort of cause. Whereas peripheral vascular disease, they've got a history of problems. So the most important thing with these EMQs is everything they give you is important. So make sure everything you read has a reason. You work out what the reason for it being there is. So this should be straightforward. It's just a farm buzzword from first and second year. 72-year-old man with left ventricular failure due to ischemic heart disease attends the hospital general clinic, and he gets started on a bunch of new drugs. He also suffers from mild asthma. He returns 3 months later complaining of breast enlargement and tenderness, and his potassium has risen to 5.8, which is well above normal. What class of drug was he started on? No. Anyone know? A, good, aldosterone antagonist. So painful gynecomastia is a common side effect of spironolactone, which is an aldosterone antagonist. The reason it's not Lasix or a loop diuretic is potassium has risen. Remember, every diuretic other than the aldosterone antagonists are potassium wasting. You pee out your potassium. So his potassium's risen because it's potassium sparing, and he's got painful gynecomastia, which is a common side effect you guys should be aware of. Just running through the other drugs, what's the common side effect for ACE inhibitors? Dry cough, good. Beta blockers? Yeah, bradycardia, exercise intolerance, nightmares, impotence, calcium channel blockers. Sorry? Constipation, good. Any others? Yeah, bradycardia, if it's centrally acting. Also peripheral edema. Sorry? Postural hypertension. That's for all of them because they all reduce your blood pressure. Loop diuretics, your buzzword is hypokalemia. They lose potassium. 2 weeks post-MI, middle-aged man is found to have ST elevation in leads V2 to V6. He is asymptomatic. What does he have, Anuj? Just running through the other drug, what's the common side effect of inhibitors? So these are all complications of an AMI. So if he's got persistent ST elevation, that's a buzzword. G, pericarditis? No, not quite. Okay. Everyone's just guessing. So it's a ventricular aneurysm. So buzzword presentation, persistent ST elevation, long after the AMI, is a sign of a ventricular aneurysm. So it's just an aneurysm, but of the left ventricle. So jot that down. 4 days after an AMI, a 58-year-old man has a sharp chest pain, worse on movement and lying down. Auscultation reveals a pericardial rub. ECG shows diffuse ST segment elevation. Lots of buzzwords. Anuj, this is yours. Pericarditis, good. So your buzzword is diffuse ST segment elevation or saddle-shaped ST elevation. So ST elevation in basically all the leads. If you had an AMI causing ST elevation in all your leads, you're probably dead. So it's probably pericarditis. So what's the difference? So someone said Dressler's before. Does anyone actually know what Dressler's is?
It takes longer than pericarditis.
Yeah, good. So Dressler syndrome is a delayed autoimmune mediated pericarditis. So I think the currently accepted theory of pathogenesis is you get antibodies forming against the dead myocardium. So 3 to 6 months later, these people are going to present with pericarditis. So the difference in the post-MI setting, acute pericarditis is a few days after, within the week. Dressler's is months after. So that's what Dressler's is, and that's how you distinguish the two. 68-year-old diabetic woman presents to ED with sudden onset epigastric pain. She is peripherally shut down. She is hypotensive and her heart rate is 120. She is afebrile. Paramedics report she was found collapsed with GTN in her purse. Next person along in the blue shirt. Yeah. Had to check if it was blue. Very good. It was. So I was sort of hoping you would fish down the abdominal aortic aneurysm part. You didn't. So remember, diabetics present atypically. She's got signs of cardiogenic shock. She's got acute collapse of her blood pressure. She's tachycardic. And the most important thing is, why would she have GTN in her purse if she had an aortic aneurysm? The GTN points to angina, right? Yeah? She doesn't just collect GTN bottles for fun. So let's talk about heart failure. Heart failure is actually ridiculously simple. The only problem with it is there's 1,000 ways to actually approach heart failure. So when you go to hospitals, cardiologists are like, oh, this person has HFpEF versus HFrEF, systolic versus diastolic, low output versus high output. So the struggle is really in trying to work out what are they talking about. So this is a really wordy slide, and I was sort of tossing up not putting it, but this was a tute I got from one of the heart failure physicians last year. And I think this one slide tells you everything you need to know about heart failure. So heart failure is a clinical syndrome where you basically have inefficient cardiac output to meet the demands of the body. So it can cause symptoms at rest in advanced disease, or otherwise in early disease, it only causes symptoms on exertion when you're exercising and your cardiac output can't cope with the increased metabolic demand. So basically what we're saying is if it's not meeting cardiac output, one of two things can happen. Either the left ventricle and the right ventricle aren't pumping blood, or there's something which is impeding venous return. So if there's no blood coming back to the heart, how do we expect it to pump? So that, in a nutshell, is how we classify heart failure. So it's characterized by edema, either in the lungs or systemically. So you can get peripheral edema or you can get pulmonary edema. And the reason we get it is neurohormonal and pro-inflammatory mechanisms. So I'll break that down. So let's talk about the neurohormonal first. So neurohormonal, let's talk about sympathetic overactivity. So let's break it down. You've got decreased cardiac output because you've got heart failure. Because of that, you start releasing adrenaline. Remember, adrenaline is released to increase your blood pressure. What does it do? It has an inotropic effect. It makes your heart beat harder. It also constricts the blood vessels. And that's where the problems start. So in someone with heart failure, they release adrenaline. Their blood pressure goes up, but because the blood pressure goes up, the heart needs to pump harder to maintain that blood pressure. So you've got vasoconstriction, so you've got relative obstruction, so the heart has to pump even harder to get blood across. And the other thing is the heart's working very fast. So if you've got an inotrope making your heart beat quicker, that means the heart has to work harder. So the adrenaline is meant to be an adaptive mechanism, but it actually gives your heart more grief. So this is where the treatment comes in. We've got high levels of adrenaline causing the heart to beat fast and also causing the blood vessels to constrict. So what are we going to do? We're going to give them beta blockers to slow the heart down. And then we're going to give them an ACE inhibitor to cause vasodilation. So that's why these slides, I hope, make sense, because they made sense to me when he said it. I'm probably just doing a crappy job of explaining it if it didn't make sense. Then there's the second aspect of it. So we've talked about the neural aspect. Let's talk about the hormonal aspect. Low cardiac output in heart failure. Your blood pressure is low. Renal perfusion goes down. What happens when there's not as much blood going to the kidneys? You start releasing renin. Renin goes through that whole renin-angiotensin-aldosterone system to produce angiotensin II. What does angiotensin do? Angiotensin II do? Causes vasoconstriction, and it also leads to aldosterone and ADH production. So remember, aldosterone and ADH preserve water and salt, so that's how you get your edema. So how are we going to block off the hormonal aspect? We're going to give them an ACE inhibitor to shut down angiotensin II, and we're going to give them spironolactone to block off the effect of aldosterone, because that's an aldosterone antagonist. So does that all make sense? So you've got all the pathophysiology summed up as neurohormonal, and basically it's told you why you've got all the problems and what drugs you use to treat it. So I could probably just stop there, and that's enough for heart failure. But too bad, you need to know more than that. So the 1,000 ways I was talking about of how to classify it. So left heart versus right heart versus congestive. This is the most commonly used method. Left heart, we're saying the left ventricle isn't pumping. If the left ventricle isn't pumping, you get a backlog of blood through the left atrium and into the lungs. Does that make sense? Because blood from the lungs comes into the left atrium and left ventricle. If the left ventricle can't pump that blood out, the blood pulls back. So you get blood pooling in your lungs. And if you remember your basic Starling forces of like oncotic pressure and osmotic and oncotic pressure and all of that stuff, basically, if there's lots of blood pooling in the pulmonary vasculature, it's going to cause fluid to leak out, and it goes into the lungs. So you're going to present with shortness of breath because there's fluid in your lungs, and that's what we call acute pulmonary edema. So the symptoms you asked for on your cardio systems review: paroxysmal nocturnal dyspnea, orthopnea. Do you get short of breath? And then buzzwords for acute pulmonary edema: do you have a cough with pink frothy sputum? That's how APO presents. These are all symptoms associated with left heart failure. In contrast, you've got right heart failure. If the right heart isn't pumping its blood out into the lungs, what happens? All the blood pools in the right side of the heart, and then it backlogs out into the venous system. So if you've got blood pooling in your vena cava, what's going to happen? You're going to get peripheral edema. You're going to get hepatomegaly, because remember the blood vessels pass through the liver. And you're going to get ascites because it's going to affect the venous return from the abdomen as well. So you're blocking off venous return, so the blood has nowhere to go, so you get fluid leaking out peripherally. Does that make sense? So that's left versus right. Congestive cardiac failure is biventricular. So you're screwed. You've got left and right ventricular failure. So they're going to have APO and they're going to have peripheral edema. Acute versus chronic, really simple. Acute is literally that. It's acute. So it's either sudden heart failure for whatever reason. So if you have a PE, you will cause right heart strain because the right heart has to pump really hard to get past the clot. So you're going to get acute right heart failure, or it's a decompensation of existing chronic heart failure. So when I say that, most of these people have to limit how much they can drink because their heart can't deal with extra fluid. They've already got all of these mechanisms causing them to have edema. If they decide to go and have 6 liters of Coke, what's going to happen? They've got a sudden increase in the amount of fluid in their blood, in their body, and all of a sudden, the heart can't cope with the extra fluid. So they're going to go into sudden acute onset edema and acute pulmonary edema. Chronic heart failure is what we're talking about, stuff occurring gradually. This is how the cardiologists like to classify it. Systolic versus diastolic. So systolic is now called heart failure with reduced ejection fraction. This is basically left heart failure. So the left ventricle has a reduced ejection fraction. It's not pumping as much blood out. In contrast to diastolic heart failure, this is heart failure with preserved ejection fraction. This has a weird bunch of causes. So remember I said you can either have failure of the pump or you can have failure of the ventricles and atria to relax so the venous return comes back. Diastolic heart failure is where you've got disease of the myocardium or pericardium, which prevents the ventricles from relaxing. So the ventricles can't fill. So if they can't fill, they can't get blood, which means they can't pump anything. So causes of diastolic heart failure, constrictive pericarditis. The pericardium doesn't let the heart expand. So how is the blood going to come into the ventricles? Similarly, you can get restrictive cardiomyopathy, which is where you get infiltration, which means the myocardium becomes stiff and it can't relax. So again, it obstructs venous return. So how is it going to pump if it doesn't have any venous return? So those are some examples of diastolic heart failure. This is a really nerdy classification you don't really need to know about, but it's basically saying low output heart failure is where you've got low cardiac output, which can't rise because the heart is screwed up. So this is typically things like an AMI causing this, or you've got high output heart failure, which is where everything is normal. But remember we said there are some causes of ischemic heart disease where the heart just has to work harder and it can't keep up with that. So in people with anemia who are pregnant, hypothyroid, so they either have tachycardia or they have increased circulation as in pregnancy, the heart's fine, but it can't cope with the increased demands. So typically these people will get better once you remove the problem. If you fix their tachycardia, you fix their heart failure. If you fix the pregnancy, as in they deliver the baby, if they deliver the baby, their circulatory volume returns to normal, their heart has to pump a normal amount of blood again. So that's just classifying the cause. Common causes of heart failure, very OSCE-related station. Know the top 4. Ischemic heart disease, majority. Hypertension. Remember, hypertension means the heart is chronically working harder, so it will eventually lead to heart failure. Valvular heart disease, which we'll talk about in a bit, and cardiomyopathy. So cardiomyopathy I won't be talking about today, but cardiomyopathy is basically any other heart condition which we haven't discussed today. So it's a group of everything else. Have a read about it. There's not a whole lot in textbooks generally, but it's worth having a look at. Common precipitants of heart failure are very similar. So it's when you get a patient in an OSCE who's presented with heart failure, so they say, you know they've had an AMI and now they've got pulmonary edema, you have to take a very focused history. So what you need to do is you need to work out why have you got heart failure. So it's important to know what causes you to tip over into decompensated or acute heart failure. So have they had another heart attack? Have they got an arrhythmia? So what would you ask them? You'd say, have you had chest pain? Have you had an awareness of your heartbeat? Have you got palpitations? Have you had syncope, which can be another manifestation of arrhythmias? Hypertension can cause you to do that. Anemia can cause it. Infections, these are really common in hospitals. So people get a cold And then the cold, because they've got a chronic disease, just gets worse, causes them to tip over. Thyroid disease is, again, quite common, but it's good because remember, it's high output. So once you fix the hypothyroidism, they get better. Pulmonary embolism, perioperative, again, very common. So these people have surgery and the anaesthetist opens up 3 bags of fluid. They've suddenly got all this extra fluid their heart can't cope with. And pregnancy, which we've talked about as a form of high output heart failure. The most important one, though, I think, is drugs, because by and large, 60% of the people who are going to turn up to hospital with acute decompensated heart failure either decided to stop taking their meds or they didn't comply with fluid restrictions. They decided to go and have 2 liters of booze. Okay, they didn't have 2 liters of booze, but 2 liters of fluid, you get what I mean. So we've talked about the symptoms already. So divide it into left heart failure and right heart failure. Left heart failure, the left ventricle isn't pumping, so blood clogs up in the pulmonary vasculature. They get pulmonary edema. These people are short of breath. Right heart failure, the blood isn't getting pumped by the right ventricle, so the entire venous return isn't getting pumped out, so it clogs up the peripheral venous return, meaning they get peripheral edema, so swollen legs, hepatomegaly, and ascites. Does that make sense? So simple. That's how if you think about it as left versus right, you've got your list of questions to ask them. That's a slide I would recommend you have a look at for your OSCEs, because in 3rd year, you're not going to get a please perform a cardiovascular exam on Mr. Smith. You're going to get Mr. Smith has presented with shortness of breath, likely due to, this is his chest x-ray. They'll give you a chest x-ray of APO. You need to work out its APO, and then it will say, please perform a relevant history or a relevant examination of Mr. Smith. So you're going to look for peripheral edema, ascites. You're going to listen to his heart, look for signs of previous heart disease. Or on the history, go through those questions. What are the common precipitants? Are you taking your meds? Have you had an arrhythmia? Have you had chest pain? Grading of symptoms is important to know. Just know class 1 to class 4. So class 1, these are people who've got heart failure but no symptoms. Class 2, these are people who've got heart failure and symptoms on moderate exercise. Class 3, these are people who have symptoms even with mild exercise. So the way you differentiate, moderate exercise would be, do you walk 500 meters and get short of breath? Class 3 would be, do you get short of breath walking to the bathroom? And class 4, they're constantly short of breath. So they're short of breath at rest. How do you investigate it? Basically, do the ECG, and you need to do everything. You need to try and work out what the cause of their heart failure is. One particular test that you might not be familiar with is something called BNP, which stands for brain natriuretic peptide. Basically, this is a hormone that is released by a stretched ventricle. So when there's too much fluid and the ventricle is stretched out, it releases this hormone. The hormone goes and acts on the kidneys, and what it does is it increases sodium excretion, which means you pee out more water, which is the whole point of it. Imaging-wise, do a chest x-ray. You want to make sure they don't have acute pulmonary edema. And do an echocardiogram. See what their left ventricular ejection fraction is like. See if there's any arrhythmias. Is there any valvular heart disease which might be causing the problem? And then there's your other investigations as well. So this is what acute pulmonary edema looks like. Easy to remember with A, B, C, D, E. So you get alveolar edema, which is this sort of fluffy, diffuse opacity, more concentrated around the perihilar region. Curly B lines are sort of hard to see on this x-ray, but you get these vertical lines, horizontal lines. Notoriously hard to see, but people see them. Cardiomegaly, enlarged heart, meaning it's more than the diameter of the heart is more than half the antero-posterior, more than half the AP diameter of the chest. Upper lobe diversion, you've got more pronounced hilar vascularity, which is up here, so you can see blood vessels, which you normally can't. This cartoon's meant to illustrate that, but I recognize it's sort of harder to see. And pleural effusions, you get blunting of the costophrenic angles. So fluid there, so you can't see the costophrenic angles, which are normally clear. How do you manage it? LMNOP. Lasix, so give them IV furosemide. Morphine, which has vasodilator effects and helps relieve the dyspnea. Nitrates, again, vasodilatory. Oxygen, because they're probably hypoxic. And positioning, so make them sit up. Remember, orthopnea is a symptom which is worse when they're lying down. So make them sit up, and you can give them positive pressure ventilation to help. Management, So, okay, so there's your lifestyle stuff, which we've talked about. I'm not going to talk about that now. Fluid management is essential. So basically these people need to be weighed daily, and we work off the presumption that 1 liter of fluid weighs 1 kilogram. So if they come in saying I put on 3 kilos in 2 days, they probably haven't eaten 3 kilos worth of food. It's probably more likely that they've put on 3 liters of fluid. So they'll have peripheral edema to correlate with that. So they need to weigh themselves daily, and most of these patients are restricted to 1.5 liters of fluid a day. Drugs. People struggle to remember these, but the way I was taught is, you guys all know ABS is like the braking thing in your cars. So the heart failure physician said, just think about it as putting the brakes on heart failure. So just remember ABS, and he's added I in because I is a new drug which called ivabradine, which I talked about before, which only recently was found to improve outcomes in heart failure. So these drugs need to be given to everyone. The reason is they have proven mortality benefit. So it doesn't matter what your heart failure is like. These drugs, everyone with heart failure should be on. So give them an ACE inhibitor, which is the A, give them a beta blocker, which is B, spironolactone, which is the S, and ivabradine, which is the I, which slows down heart rate. And just remember which beta blockers are more cardioselective and which ones aren't. For symptomatic treatment, because they've got fluid overload, give them diuretics. If they've got arrhythmia, especially atrial fibrillation, which is very common with heart failure, you can give them digoxin. For other arrhythmias, you give them whatever drugs you use to treat those arrhythmias. You can give them nitrates if they're having chest pain. And then you reach your procedural interventions. So these are like your last line. They're really going down the hill. Procedural interventions, once their left ventricular ejection fraction is less than 35%, normal is more than 50. Once it's 30 to 35%, you give them biventricular pacing, which is cardiac resynchronization therapy, which basically forces the heart to contract. So if you're forcing the heart to contract, you're forcing it to pump blood. You give them an ICD. These people are at a huge risk of VF and VT once their ejection fraction is less than 30%. So you should start thinking about giving them a defibrillator. And then you've got your ventricular assist devices, which are mechanical pumps and cardiac transplant. You aren't expected to know about any of those in detail. Complications. We've talked about acute decompensation, which is your sudden acute pulmonary edema or peripheral edema. If you guys take a history from someone with APO, it'll be incredibly characteristic. They say, I was walking down the kitchen and then I was on the floor because I couldn't breathe. It's that dramatic. So try and talk to people who are in with APO because they'll give you a really good history. Side effects from medications are obviously problems, such as your potassium going off. Arrhythmias are really common. We've talked about that, especially VF and VT in end-stage disease. And then you've got hypoperfusion of the kidneys. So the kidneys may get damaged. You might get hepatic congestion, which means you're off your food and you get a painful right upper quadrant. And then pulmonary hypertension, which will be talked about more in Rohit's lecture. So I think I should be done in maybe 20 minutes. Do you want me to power through, or do you guys want a 5-minute break? Okay, 20 is optimistic if we go slowly with questions, but soon. The next bits are really, really quick. They're not core content. They're just no buzzwords. Power through? Power through? Okay. Here is your summary of murmurs. Basically, these are all the murmurs you'd be expected to know. So if you do nothing other than memorize murmurs, please memorize this table. It'll probably get you a lot of marks. So in terms of the murmurs, let's just go through them. So everyone's comfortable with the first and second heart sound. So the first heart sound is your atrioventricular valves, which is your tricuspid and mitral valves closing. And your S2 or second heart sound is your aortic and pulmonary valves closing. Everyone's happy with S1, S2, right? So systole or systolic murmurs are between S1 and S2 because that's when the ventricles are pumping. Diastole is after S2 and before S1. So it's important to know where systolic and where diastolic is. So in terms of the murmurs, aortic stenosis is the most common valvular pathology you'll come across. It's an ejection systolic murmur radiating to the carotids. If there's 2 murmurs you learn, please learn aortic stenosis and mitral regurgitation because they're the most common. So when your cardiology bedside tutor says, oh, what do you think of this murmur? If you have no idea, which is 90% of the time, work out if it's systolic, work out whether it's ejection systolic or pansystolic, meaning it goes all the way through systole, And then once you know if it's pansystolic or ejection systolic, just say one of those two. It's probably going to be one of those two. Aortic sclerosis is a precursor to aortic stenosis. We'll talk about these two conditions in detail. It's ejection systolic murmur with no radiation. So the difference is aortic sclerosis is not pathological and does not radiate. Aortic regurgitation is another one of the big murmurs. Wouldn't hurt you to know. You should probably know it. It's an early diastolic murmur. So that's how you remember it. There's two diastolic murmurs you need to remember. Aortic regurg, which is early diastolic, and it's not heard. So all of these are heard best over the valve affected, other than aortic regurgitation. So if you think about aortic regurgitation, the aortic valve is incompetent. So the blood goes out, the valve is meant to close, but it doesn't. So during diastole, when the blood's up in the aorta, blood comes back through the leaky valve and it comes back into the bottom of the left ventricle. So that's heard best over the sort of tricuspid or mitral valve area because the blood is rushing back. So it'll be loudest, not over the aortic valve, but down where the ventricles are. The other diastolic murmur you need to know is mitral stenosis, which is mid-diastolic. And it has an opening snap, which is another buzzword. So these are all buzzwords that you should know. So if someone says early diastolic murmur, louder on expiration, you should be able to circle aortic regurg to move on. So that's the kind of knowledge you should have about at least the buzzwords by the end of this. Mitral regurgitation is a pansystolic murmur, and it's one of the murmurs which radiates. It radiates to the axilla. So aortic stenosis goes up to the carotids. Mitral regurgitation is pansystolic and goes to the axilla. Mitral valve prolapse is where one of the leaflets of the mitral valve gets sucked in. So it causes a late systolic murmur with a mid-systolic click. If anyone wants to talk about the pathophys of each of these murmurs, I didn't have time to go through it today. As you can see, there's a lot of content. I'm happy to talk to you about why each of these occurs at that particular time in the heart, in the cardiac cycle. Tricuspid regurg is important to know because it's associated with a lot of buzzwords. So tricuspid regurgitation is a pansystolic murmur. The way you differentiate this from mitral regurgitation is it doesn't radiate to the axilla. The only other one, so these are all congenital heart disease. We got taught them last year, but I would question needing to know these three. I think they're more pediatrics in fourth year, to be honest. So don't worry too much about them. Hypertrophic obstructive cardiomyopathy, I'm not going to talk about today because it's a cardiomyopathy, but that causes an ejection systolic murmur. And I have a question on it later so you can get the buzzword sort of presentation of how it presents. So don't worry about the next three. And then a flow murmur. A flow murmur is anything associated with hyperdynamic circulation. So anything which causes your cardiac output to go up, be it anemia, be it hyperthyroidism, be it pregnancy, you've got greater cardiac output, that will cause a flow murmur, which is a mid-systolic murmur, and it's benign. Obviously, they've got hyperthyroidism, so you should probably fix that. But the murmur itself doesn't indicate any problems with the heart. So if you listen to a kid's chest and he's got a roaring fever, because he's tachycardic, he's going to have increased cardiac output, so he'll probably have a flow murmur. So what you want to do is, it's a systolic murmur. Could it be something serious? I'm going to come back in 3 days when his fever's gone away, and I can listen to it again, and it should have disappeared. So let's talk about each of, I've only made notes on about 4 or 5 of the valvular pathologies you should know. Like, don't worry about pulmonary stenosis and pulmonary regurgitation. The ones I've put on here are the ones Monash definitely expects you to know because they're common. So aortic stenosis narrowing aortic valve. So it's a narrowing of the aortic valve. The most common causes are old age. So you get calcium deposits like you do in your arteries. You get calcium deposits on the valves and the valve screws up over time. Other causes are a congenital bicuspid valve, remembering the aortic valve is normally tricuspid, but in this case it's bicuspid. And it has a very classical presentation. So think of SAD, syncope, angina, and dyspnea on exertion. That's how it presents. Symptoms are a late sign. So until they have critical stenosis, they're not going to have symptoms. So if you hear a murmur, you should probably start getting onto it. But if they have symptoms, that's a definitive indication to fix the valve. So you can fix the valve in one of 2 ways. You can either do a transcatheter valve implantation. So they go up through the groin with a portable valve, like a squeezed up valve, and they deploy it. Or you can do open heart surgery to repair the valve, which is more common. The other buzzword sign, so obviously there's the ejection systolic murmur radiating to the carotids. The other buzzword sign is narrow pulse pressure, because so the difference between systolic and diastolic blood pressure is narrow, and they've got a slow rising pulse with a pressure loaded apex beat. Again, if you want to understand the pathophys of this, shoot me a message or talk to me after the lecture. Happy to go through it. Aortic sclerosis, remember I said this is the non-pathological version of aortic stenosis. It's thickening, but the valve itself is normal. So there's no obstruction, there's no regurgitation, the valve is good. So they're asymptomatic, but they have an ejection systolic murmur. So it's thickening of the valve, but the valve is still fine. Whereas with stenosis, there's thickening of the valve, but it means that there is an outflow obstruction, because the thickening of the valve means the left ventricle has to pump harder to get blood past the obstructed valve. Over time, this may progress to aortic stenosis, but the way to distinguish it is there is no radiation. These murmurs, guys, especially if you're at the Alfred or MMC, hit the cardio wards, there will be people with these murmurs. So during your cardio term, you should at least hear a couple of each of these. Aortic regurgitation. So this is a leaky aortic valve. So during systole, the left ventricle pumps blood into the aorta. The valve should close, but it's leaky. So during diastole, there's blood still coming back. So the blood should all be going out into the circulation, but it's coming back because the valve's leaky. Almost always caused by aortic dilatation, usually idiopathic, but the two causes you need to be aware of are rheumatic heart disease and Marfan syndrome. So the buzzwords, it's an early diastolic murmur heard over the tricuspid valve. Remember, the jet of blood comes back down into the ventricle, louder on expiration. There's a wide pulse pressure, so there's a bigger difference between the systolic and diastolic pressure. And there's a volume loaded apex beat, because the heart has more blood it needs to now pump out, because you've got the regurgitating blood plus what's coming back from the lungs. So you need to pump it harder. It's got 1,000 eponymous signs. So Quincke sign, which are capillary pulsations, collapsing water hammer pulse, also called Corrigan's carotid pulse, de Massey's sign, where the head bobs with the heartbeat. You're not going to see this stuff. Like, it's just fun to know about. But maybe know the collapsing pulse, because that's got to do with the wide pulse pressure. Management is the same. So for all these valvular heart diseases, you treat the problems it's causing. If it's causing an arrhythmia or a heart failure, fix that, and then take them to surgery. Mitral valve prolapse. So this is where, as I said, a leaflet gets sucked into the left atrium during ventricular systole. Remember, it shouldn't do that. So that causes a late systolic murmur with a mid-systolic click. Just learn what the murmur is. That's more than enough for mitral valve prolapse. Mitral regurgitation is a leaky mitral valve. So during systole, blood shouldn't be going back into the left atrium, but it does. So as I said, it's a pansystolic murmur radiating to the axilla. And if there's a regurgitation of blood into the left atrium constantly, as you can imagine, over time, the greater amount of blood in the left atrium will cause the atrium to dilate, because there's this constant rush of blood coming back. And dilatation of the left atrium will disrupt the atrial electrical conduction pathways. So these people have atrial fibrillation. So atrial fibrillation is one of those characteristic symptoms associated with mitral valve disease. Again, you can take them to surgery and treat their heart failure. So surgery for mitral valve pathology is interesting, because they can now do it robotically. So it doesn't have to be open heart. It can be 3 or 4 tiny incisions. Mitral stenosis. The reason you need to know mitral stenosis is because rheumatic heart disease, which I'll talk about in a bit, but it's a long-term outcome of rheumatic fever, which is infection with group B strep. You'll get infectious diseases lectures. So group B strep will mean something to you, hopefully, at some point this year. But it's associated with rheumatic heart disease. Your characteristic presentation, it's more common in Indigenous Australians, because they get strep throat, which is pharyngitis. They don't get antibiotics for it because healthcare isn't as great amongst rural Indigenous communities. And as a result, they get rheumatic fever, which can cause rheumatic heart disease. So this is one of the 2 diastolic murmurs you need to know. This is a mid-diastolic murmur, louder on expiration. Again, fix it with a catheter, a transcatheter, or open heart surgery. Tricuspid regurg. So tricuspid regurg is an incompetent tricuspid valve. I think you're getting a theme now. So regurgitation incompetent. Clinically present. This has a lot of characteristic signs you should know. Elevated JVP with giant V waves. The reason this happens is the right ventricle contracts, blood goes back up into the right atrium and up the superior vena cava, up into the jugular vein. So your JVP goes up each time the heart contracts. So it's giant V waves. So V meaning it's associated with the ventricular contraction. You get pulsatile hepatomegaly. Blood goes back out the left atrium, down into the inferior vena cava, which will cause the liver to become pulsatile. And you've got a pansystolic murmur. Remember, to distinguish this from mitral regurgitation, it doesn't have any radiation to the inside. So in third year, it's really easy, and this really pisses off cardiologists beyond measure. It's important not to say hypertrophy and dilatation as meaning the same things. Hypertrophy means there's more myocardium. Dilation means that you're stretching out the myocardium and the ventricle. So if you say dilatation, you're saying it's thinned and stretched out. If you're saying hypertrophy, you're saying the myocardium is thickened. So dilatation will cause cardiomegaly. So the heart, the apex beat moves across. Hypertrophy will cause a more forceful beat because the heart's beating harder. Does that difference make sense? So don't use them interchangeably. Someone will pick you up on it and give you basically this lecture, but a more protracted course. Okay, quickly want to rip through these murmurs. We've talked about most of these. 18-year-old male okay, we haven't talked about this one. 18-year-old male suddenly collapsed halfway through his school football game. On arrival to hospital, an ejection systolic murmur was noted. There was no radiation. His mother reports a family history of sudden unexplained cardiac death. So where are we up to? Sorry, I don't know your name. Sorry? Good, Hockham. So we didn't talk about hypertrophic obstructive cardiomyopathy. So basically what this is you get septal hypertrophy. So the interventricular septum becomes thick. And when the heart has to beat quicker and harder, as happens with exercise, it basically obstructs the left ventricular outflow tract. So it blocks off the aortic valve. So the blood can't exit the left ventricle and they get collapsed because of it. And they can get arrhythmias as a result of it. So characteristic presentation, there's a family history of sudden cardiac death. And on physical exertion, a young, otherwise fit, healthy person is going to collapse. So that's your characteristic buzzword presentation. Obviously, it would be good if you went home and read a little bit more about it, but I'm sorry, I won't have time to talk about cardiomyopathy today. Tall, slender man presents to the clinic. On examination, he's found to have capillary pulsations, long, slender fingers, a wide pulse pressure, collapsing pulse, and early diastolic murmur. Actually, we might skip you because you answered this one. We'll go back. It's okay. It's a small group, so. Tall, slender man. What does that mean? Good. Marfan's. What do you remember? Okay, let's leave it at Marfan's. Early diastolic murmurs. What were the two diastolic murmurs we talked about? Okay. Aortic regurgitation, which was early diastolic. Mitral stenosis, which was mid-diastolic. So if you remember your two diastolic murmurs, you already know it's one of those two. Yeah, so it's aortic regurgitation. What does the Marfan's have to do with it? It's a connective tissue disease. Remember I told you with stuff like aortic pathology causes your aortic root to dilate. So if you stretch your aorta out, the valves of the aortic valve get pulled out as well and you get a leaky valve. Does that make sense? And you've got capillary pulsations and a collapsing pulse, which again are buzzwords. So I know it takes time to learn these buzzwords, so just go home and keep on flicking through the slides and you'll get the hang of it. Bit of a trickier question. 60-year-old Bangladeshi woman presents to the clinic with a rash on her abdomen, a low-grade fever and polyarthralgia. She reports that her grandson recently had a sore throat, which was treated with antibiotics. She has had similar episodes of these symptoms when she was younger. On examination, she has a mid-diastolic murmur with opening snap and tapping apex beat. So you can ignore basically the first three sentences if you want. You've got your buzzword sentence at the end. What is it? Very good. Mitral stenosis. Anyone know what all the Bangladeshi heritage and the low-grade fever polyarthralgia is about? Not rheumatoid? Yeah, rheumatic fever. Good. So rheumatic fever, her grandson has strep throat. She probably had strep throat as a child. she probably didn't get antibiotics for it. And as a result, she's developed rheumatic heart disease. 14, a middle-aged man with a long history of chronic lung disease and secondary pulmonary hypertension is noted by his GP to have an elevated JVP with giant V waves and pulsatile liver. We'll stop there. What's that? TR, tricuspid regurgitation. Good. Now let's read the next bit. He explains having lost weight. He complains of having lost weight over the past few weeks and has a constant low-grade fever. On examination, he has splinter hemorrhages and palpable tender lesions. On auscultation, he has a pansystolic murmur radiating to the axilla. What does he have? Mitral regurg. Secondary to what? Why does he have mitral regurg? Infective endocarditis. Yeah, remember splinter hemorrhages and palpable tender lesions, which are Osler's nodes. So the things you look for on a cardio exam. So this is actually 2 murmurs. Sorry, I was feeling sneaky with that. 75-year-old man with a long-standing history of chest pain and dyspnea on exertion, presumed secondary to ischemic heart disease and COPD, suddenly collapses as he walks to collect his mail from the letterbox. A murmur is heard by the intern in ED, but he cannot characterize it. So next person along in the white shirt. Yeah. Oh, okay. Ooh, sure. Next person along. Sorry, I'm bad with names. Okay, what symptoms has he got? Sorry? He's got SAD, yeah. So syncope, angina, and dyspnea on exertion. Aortic stenosis, very good. Easy. So as you can see, it's just pattern recognition with a lot of the murmurs. A young lady presents to the GP with palpitations, weight loss, heat intolerance, and fatigue. On examination, she has an ejection systolic murmur with no radiation. Next person on the white shirt. You can talk through it if it's... No? So have a look at the history. What do those symptoms all point you towards? What diagnosis? And you know this condition. It's a preeclamptic condition. Palpitations, weight loss, heat intolerance, fatigue. A young lady presents to the... Does that remind anyone of a particular disease? Someone yell out. Hypothyroidism. Yeah. So she's got hypothyroidism and now she's got an ejection systolic murmur. So put the two together. Remember I talked about hyperdynamic circulation, where you've got increased cardiac output. Not sure? Anyone? G, it's a flow murmur. So she's got hyperdynamic circulation secondary to thyrotoxicosis. Arrhythmias are actually really quick. So there's reporting an ECG. I'm going to confess I still hate interpreting ECGs. They're so confusing. So they're like the dread of cardiology. But classifying arrhythmias quickly, this is the last bit. Yeah. And then it's just like 5 questions after. Arrhythmias quickly. You can divide them into tachyarrhythmia, so tachycardia, and bradyarrhythmia, so bradycardia. So tachycardias, we can actually now split into wide complex and narrow complex. So in third year, the way to split it is you look at the QRS, is it a wide or broad QRS or a narrow, thin QRS? So what the difference is, if it's a narrow complex tachycardia, it's supraventricular in origin. It's atrial in origin. So your differentials with a tachycardia that's narrow complex automatically drops to these. And the ones you really only need to know are sinus tachy, atrial tachy, AF, and atrial flutter. Broad complex tachycardia is a pathology from your ventricles, so that's VF and VT. So that's the presentation. Don't worry about that too much. Let's just talk about AF, buzzwords, absent P wave, and irregularly irregular rhythm. I'm just going to race through this now. Learn the classifications of AF. If it's idiopathic in a young, otherwise healthy person, it's called lone AF. If it's occurring occasionally, but it goes away itself, it's paroxysmal. If it's persistent for more than 7 days or only going away when you cardiovert them, so you give them an electric shock, so defibrillate them, it's persistent. And if nothing works to fix it, it's chronic. So it's worthwhile knowing and know the most common causes. The most common being valvular heart disease, AMI, alcohol, and hypothyroidism. Management's really simple. So we've talked about AF giving you an increased risk of clots, correct? So in terms of increased risk of clots, you want to anticoagulate them, and then you want to restore them to sinus rhythm. And then the third thing is they're tachycardic, so let's slow down their heart. So you've got two options. You can either reduce their rate and anticoagulate them forever, or you can give them cardioversion, which means you restore them to sinus rhythm. In terms of the morbidity and mortality, there's no difference between the two. So there's been studies to indicate you can do whichever one you prefer. So rate control, give them beta blockers. Anticoagulation, give them warfarin or the new anticoagulant, so apixaban, dabigatran, rivaroxaban. Cardioversion, you've got to cut off. If they've been in AF for less than 48 hours, they probably don't have a clot. So go ahead and cardiovert them. If they've been in AF for more than 48 hours, they probably do have a clot somewhere, which is likely to embolize. So you anticoagulate them for 3 weeks, you give them the cardioversion, and then anticoagulate them for 4 weeks more. So that's how you fix it. So ideally, cardioversion is with a shock, but you can also give cardioversion with 3 drugs: sotalol, amiodarone, and flecainide. Everything I've said here, you should know inside out. This is the arrhythmia you need to know. How do you decide what anticoagulant do you give? Do you give them warfarin? Do you give them aspirin? Do you give them nothing? There's this score called the CHADS-2 VAS score. Learn the criteria, learn the points. Basically, if they've got a score of 2 or more, they should be on warfarin. If they've got a score of 1, aspirin or warfarin, but you prefer warfarin. If they've got a score of 0, they need nothing, or you can give them aspirin. You need to know that because they have asked that in the past in OSCEs. Atrial flutter is your characteristic sawtooth pattern. It's got an atrial and ventricular block. So there's a nodal block. So the atria go at its own rate, the ventricles go at their own rate. It's a tachycardia. And the characteristic presentation, if it's a 2-to-1 block, so there's 2 atrial contractions per 1 ventricular contraction, there's a heart rate of 150. If there's 3 atrial contractions for 1 ventricular contraction, it's a heart rate of 100. So sawtooth pattern, and they have an exact heart rate. That's how it presents. You treat it as you treat AF. Sinus tachycardia, I'm sure you all know. Exercise, pain, fever, stress, coffee, all causes of sinus tachycardia. So everything's normal. How do you manage supraventricular tachycardia? You should have a rough idea of. The first line is a Valsalva maneuver or a carotid sinus massage. Second line is the drug you need to know. It's adenosine. Don't worry about third and fourth. And if you want to prevent it from happening, give them beta blockers because you slow their heart rate down. Ventricular tachycardia we've talked about, right? So defibrillate them. You can read all of that, but bottom line, defibrillate it. So you have different types of ventricular tachycardia. You've got monomorphic, where all the QRSs look similar, or you've got polymorphic, where they all look a bit different. But bottom line, defibrillate. Toussaint's the point, I don't know how to say this, TDP. I don't do French. This is a subset of ventricular tachycardia. The only reason you need to remember this is it's associated with long QT syndrome, where your QT intervals prolong. Just need to know that the two are associated. Don't worry too much about them. But if you give people with long QT syndrome certain drugs, or just giving people these drugs, antiarrhythmics, erythromycin, antibiotics like ciprofloxacin, antihistamines, people can have this variant of ventricular tachycardia called TDP. Ventricular fibrillation, again, cardiovert. And initially it's coarse ventricular fibrillation where the waves are bigger. Eventually it'll become fine. Hyperkalemia, buzzword, tall tented T waves. I've got that over here. Hypokalemia, flattened T waves. So arrhythmias, as far as EMQs and OSCEs are concerned, no atrial fibrillation, no supraventricular tachycardia, and no for VF and VT, you need to be able to defibrillate. That's all the tachyarrhythmias done. This is one of the weird ones that has a couple of buzzwords, so I've thrown it in here. They have Wolff-Parkinson-White is where you have an accessory conduction system. All you need to know is it shortens your PR interval and it gives you delta waves. So what delta waves are is this sort of morphology. There's no R wave, and you've got this smooth upsloping QRS complex. That's a delta wave, and you'll notice the PR interval is shortened. So that's all you need to know about Wolff-Parkinson-White. Bundle branch blocks. Do you guys remember William Marrow? The reason I'm not spending too much time on this is most of this should be revision for you. William Marrow was that weird thing where you look at V1 and V6, is it an M, is it W, and you still have no idea at the end of it. Surprise, here's an easy way to do it. Look at lead 1, look at the QRS. If the QRS complex is broad, it's a right bundle branch, and positive and broad, it's a right bundle branch block. If the QRS complex is wide and negative, it's a left bundle branch block. It's as simple as that. As long as you don't start looking at incomplete bundle branch blocks, that works. For Monash purposes, you just need to know left and right bundle branch block. Everyone happy with that? Don't worry about digoxin. Bradyarrhythmias, the only ones you need to know are AV nodal blocks. So you guys should remember this from first and second year. First degree heart block, you've got a prolonged PR interval, but everything's normal. Second degree type 1, your PR gets longer and longer, and then you drop a QRS. Whereas in type 2, your PR is normal, but you just randomly drop your QRSs. Third degree, you've got complete block, so the P waves and the QRSs work at their own rate. That's a summary of that. Have a look at that in your time. Don't worry about Cushing's. And pericarditis we've already talked about, right? So pericarditis was inflammation of the pericardium. You get chest pain, pericardial friction rub, and diffuse saddle-shaped ST elevation in all leads. There's a list of your causes. ECG is diagnostic. So this is just overlapping. And there's your ST elevation that we talked about. In terms of management, all you need to know is give them anti-inflammatories. That'll fix the problem. It'll cure the pain. If they get recurrent or continuing pericarditis not responding to anti-inflammatories, you can give them colchicine, which is one of your rheumatic drugs for gout. In terms of complications, you can get an effusion, and the effusion can lead to tamponade, which again is a condition you would have learnt in first and second year. Pericardial effusion, collection of fluid in the pericardial sac. The reason it's a problem is it doesn't let the heart contract, and eventually it'll get so bad that it will cause tamponade. So there's so much fluid that the heart can't effectively contract, and you go into acute heart failure. So all you need to know for cardiac tamponade and pericardial effusion is tamponade has a characteristic triad called Beck's triad of hypotension, increased JVP, and muffled heart sounds. So that's how these people present in EMQs and in real life. They've got all three. That's a sign of tamponade. The other thing is if you look at the ECGs, you'll notice all the QRSs are a lot smaller in height than they should be. That's called low voltage QRS complexes. And also, see how there's alternating between a small QRS and a big and a small and a big? Do you guys notice that? That's called electrical alternators. That's another buzzword for pericardial effusion or tamponade. In terms of treatment, you put in a needle and you drain the fluid. Pericardiocentesis, easy. The other buzzword sign is this thing called Kussmaul sign in tamponade, where they take a deep breath in, but their JVP goes up as opposed to going down. So that's because there's no ability for ventricular relaxation. And that's about it. Infective endocarditis you all know about. I've put that in just for your revision. Rheumatic fever, I was hoping to talk about, but I think I'll leave it to your ID revision lecture because it's more relevant to that. But these slides sum up everything you need to know. So I've got 5 or 6 questions. Do you want to go through that, or do you want to go through it at home? I'm not too fast. Go through it now? Now? Okay. Reduced voltages and alternating heights of QRS complexes. Where are we up to? There we go. Yeah, flowery black and white top. So we just talked about this. Pericardial effusion, not an option. Is there another option which matches? So what happens when a pericardial effusion gets bad? Cardiac tamponade. That's your answer. So just quick buzzwords. ST elevation in leads B4 to V6. This should be nice and easy. Anterior infarct? Lateral infarct. Good. It's just a lateral stem. Good. This ECG is characteristic for what condition? Sabrina? So what's the abnormality? Sorry, it's a bit small, isn't it? Are there P waves? Yeah, it's a bit flat, but P waves are normal. Don't worry about that too much. QRSs, do they look all right? Are they broad, narrow, normal? Good. ST segment? What leads? 2, 3, 4. Any other leads? What about pericarditis? Yeah. So there's ST elevation basically everywhere. Leads 1, excuse me, leads 1, leads 2. There's a bit in V2, V3, V4. It's too big to be an AMI. So it's pericarditis without effusion because you don't have your electrical alternates and you don't have your low voltage. Yes.
Or can you quickly point out the saddle shape?
I don't get the saddle shape. I just see the ST elevation, to be honest. The saddle shape is one of those old.
It's in V2.
V2?
So you can see the T wave and the T wave.
Oh yeah, sure.
So
That's a saddle. I don't ever rely on that. I just look for ST elevation. It's quicker. Okay, this should be a really easy ECG. Atrial fibrillation, great. So no P waves, there's no P waves anywhere. And irregular pulse, atrial fibrillation. 50-year-old man with a central crushing chest pain collapses in ED, a code blue is called. What's the arrhythmia? VFib, good. So VT, they're often conscious with palpitations, they can collapse, but in the setting of central crushing chest pain, it's probably an AMI. We didn't like this question. It was on one of those Monash exams that they've released. Lots of debate, but what we got told at the Alfred as well was that it was VF, because VF is more consistent with the collapse. 3 more questions. 30-year-old overworked manager presents to the GP complaining of intermittent palpitations. As she entered the room, she was noted to be disposing a disposable cup into the rubbish bin. Sinus tachy, why? Coffee, good. So she's probably had a coffee and she's in sinus tachy.
what kind of be like?
Yeah, it's one of the fun ones. 35-year-old man presents to outpatient's cardiology clinic complaining of palpitations and repeated episodes of loss of consciousness. On examination, he is bradycardic with Canon A waves seen in his JVP. This is a bit of a trickier one. I've already asked you a question, haven't I?
3 more questions.
Have I? No? I have, okay. Skip over. Yeah. Okay, which ones of these are bradycardias? Let's just go through them. Would that cause a bradycardia? No, not really. That be bradycardic? Potentially, yep. Hyperkalemia? No, messes with the T waves. We don't like myocardial infarction. Is atrial fibrillation a bradycardia? No, it's a tachyarrhythmia, good. VT? No, probably not. AMI we don't like. Left ventricular aneurysm, what was the buzzword for that? I've already asked you. Persistent ST elevation. Pericarditis, we've had, probably not. Diffuse ST elevation. Sinus tachy, probably not. Long QT, no. That's just a weird one I threw in. NBF, probably not. So out of all of those, which ones are consistent with the bradyarrhythmia? C, complete heart block. So Canon A waves, I know I didn't talk about, but that's why I threw this question in. Canon A waves on the JVP is a buzzword. I don't think you'd ever be able to identify it in real life. You'd notice that the JVP is higher up, that's about it. But Canon A waves, that's your buzzword for complete heart block. Next along, young male presents to ED with sudden onset palpitations and dizziness. His ECG reveals a QRS abnormality and shortened PR interval. Pericarditis, we've had. So shortened PR. Long QT, no. Does that ring any bells? So out of all of those. Nah. How about one of the weird ones? It is Wolff Parkinson White. So what's the QRS abnormality I'm hinting at there? If I wrote it, it would have been way too obvious. Sorry? No Q. So you get delta waves, which is that smooth sort of upgoing R wave. Last question. 35-year-old brought in by ambulance to the ED with profound hypotension and collapse. His heart sounds are difficult to hear, and his JVP appears to rise with inspiration. Last question for you. H, cardiac tamponade. Correct. So what's that triad called? Beck's triad. Awesome. So the only thing that I would highly recommend you go through is cardiomyopathies. Just get a brief idea. So there's a few. There's hypertrophic. There's HOCM, which is a subset of hypertrophic. There's dilated, and there's restrictive. So just get a rough idea of what each of them are, because they all cause heart failure type things. So it's worth your time just having a flick through. Open up Robin's basic pack. It's got a great summary. That's it, guys. Sorry it went a bit over time, but you now know cardio, hopefully.
And on behalf of MUMUS, thanks to Sarthak Tandon for that amazingly comprehensive lecture.
No worries.
Well, actually, some
Of course.
so this is 5